here for the right reasons and not just a... yeah.
Of course they're here for the right
Inspiration.
reasons.
They chose the inspiration theme, right?
I tell you. They don't know what they're in for.
No. I kind of know, which is good.
But now having Breakout, there's plenty of people here.
Oh.
You just don't know. Like, it's sort of like... Oh, no, it's going to be difficult. It's kind of
Well, my boss last year, last time that did the 2:30 session. And
Hey, Ma. How are you? Yeah. We're doing it 3 o'clock. Someone's got a few people that 3 o'clock session. And then, because it doesn't actually finish until 5. Like, there's a 4 o'clock. There's a 4 o'clock kind of wrap up.
Yeah.
Which is, I remember going to it last year and it was actually really good. But it's difficult, isn't it? It doesn't.
It's a long, because we all get in it Sunday night as well. Like,
Yeah.
I think
Yeah.
I can hear that the sound's working, so thanks for that.
Yeah, we just did a kind of
You did the testing with them?
Yeah.
Yeah, we're about a minute away.
Stacey Williams, hello.
You get the full name, Stacey Williams.
Sorry. Yeah, like me. Full house, Jen.
It is going to be a full house, so it is. Are you good?
This is wonderful. This is wonderful.
A little idea.
Our little superstar.
You had the idea, actually.
Yeah, that's right. And then, I'm just going to be talking to it later. Grab me a seat.
Yeah, no worries. If you start to hear that hum behind the speaker, just move this.
I'll literally be talking for like the first 2 minutes and then I'm going to be sitting down. So,
Sweet.
do you want to? I don't know if you can remote turn it off. Or
Yeah, I'll mute it when you get off stage.
Yeah, cool. Are we ready to start?
Yeah, let's go.
Good morning, everybody. We have a full house. That's very exciting. We're a bit worried that we wouldn't have a good turnout, so that's great, very exciting. Hi, my name's Nguyen Tran. I'm the National Manager for Growth and Distribution at EML, and I've actually got a note here to say introduce myself, because I always forget to introduce myself when I'm opening these things. Now, before we get started, first of all, who attended the awards night last night? And keep your hands up if you kicked on. Oh, yeah, I already knew who kicked on and who didn't, but yeah, thanks for outing yourself. So you're here today because you've chosen the theme of inspiration. So that's, and we're very glad you've made it this morning. So from the awards night last night, one of the things that really stood out with the award winners and the nominees, and pretty much everyone in the room in general, was the amount of empathy shown towards each other, the people that were up for awards leading with empathy, the things that we all create together to try to help people get their lives back or to return them to work. So today's theme, Return to Work Superpowers, really is talking about empathy, collaboration and facilitation as the superpowers to helping people get back to work. We've got an esteemed panel, so you won't have to hear from me much longer, and I'll introduce them now. So Jenny Chait, I actually got to chat to her yesterday for a little bit, just to hear a little bit about her story. She's going to be sharing, some really a wonderful story about her work in the education system, her experience with mental injury, and the lived experience gained through, I guess, recovering from the mental injury. So very powerful story. So these days she delivers impactful workshops for big empathy and helps organisations build psychologically safe workplaces. Next up, we've got Darren Brandis up the end there. Darren's the Executive General Manager and the co-founder of PeopleSense, which is owned by Altius. I've just worked that out. Thank you. So Darren's going to share his experience spanning 3 decades of delivering counselling, trauma treatment, coaching and organisational wellbeing solutions as a registered psychologist. Darren's also really dangerous. He's also a registered or qualified hypnotherapist and fellow of the University of WA and an APRA award winner, which is like the PIEF awards, but as well. Bigger? Yeah, we'll call that. We'll go with that. Last but not least, I've got Sharon here who is going to be running through a very big day. So she's also got a workshop, a 90-minute workshop in the afternoon and a couple of podcasts. So yeah, big day. Sharon's a physio with a master's in mental health, so she's a bit of a unicorn. As the head of customer for Altius Group, she also leads the strategic and customer solutions. Sharon's a speaker, mediator, and program developer, which includes delivering award-winning national wellness programs for the ABC. She's recognised as an Insurance Business Elite Woman of 2024 and serves as the chair for Young Regional Conservatorium. Glad I got that out. So I'll leave you to the panel now. Thank you.
Thank you. And thanks so much everyone for coming along. First big session or second session after a big day yesterday. When we talk about the theme of inspiration, the lady sitting to the right of me is very inspirational, and what we wanted to do in this session was really look at mental injury claims in a way sort of sharing what works and from a positive perspective. We know that psychological claims are complex, they're often hidden, they're often hard to get good outcomes, and what we really wanted to do was, I guess, take the lid off a psychological claim and look at what worked, what went well, and particularly looking at the themes of empathy, of collaboration, and really just sharing from Jen's experience and then the expertise of Darren as a treating psychologist to really help understand why what worked as well. And so we really want to make this session quite practical and with some really sort of practical context in terms of influencing what you could take back to your roles, whether it's as an employer, whether it's as a claims manager, whether it's as an IMS, whatever your role is in the ecosystem of injury management. Our goal is to really hope that you walk away with something that's very practical and tangible that can change the way that you look at and influence the psychological claims that you have. So to kick us off, Jen, what I'd really sort of ask is that can you share with us what your experience was in terms of the psychological workplace injury that occurred?
Thank you, Sharon. Here we go. I have a lifelong mental illness and I have exceptional mental health at the same time. I worked as a teacher for 17 years, a job I absolutely loved. I adore teenagers. One day, my micromanaging manager herded 7 of us into a confined space. She screamed, she spat, and she shook because someone had asked, and she didn't know who, had asked about tablecloths for the Year 12 graduation. Something in me broke. In an instant, I went numb, I couldn't hear, I was dizzy, I was struggling to stand, and I had a memory. So a memory was extracted, a hidden memory from my childhood. It was such a clear memory that I had no memory of. It was such a clear vision that I could nearly see it. It was my mother strangling my brother. And I was terrified. My upbringing was very violent. My mother had untreated schizophrenia. That memory I had no recollection of. I sort of looked around the room, and my colleagues, they were just looking at me. I staggered out of the staff room, I staggered into the car park, and I headed for my car. I looked like I'd just drunk a bottle of scotch. I was staggering. I couldn't really see properly. I passed more colleagues, nobody helped. I was utterly alone, and I have never felt so alone and afraid in my life. I got to the car and I called my husband. I couldn't believe it, but our daughter has been training my husband to answer his phone, and he picked it up. He knew immediately there was something really wrong. We talked, I don't know how long, and he talked me down so I could drive the 10 minutes home. I have been treated by a psychiatrist for 30 years. So after contacting him the following day, he said, I can get you back to work in 6 weeks. I'm sorry, Jenny, this is a true memory. We're going to go over this. I'm sorry this has happened to you. It is a true memory and we'll process it at a time. In 6 weeks, I arrived back to school. I actually couldn't wait to see my students. They flocked to me and it was really lovely. I opened the staff room door. My manager greeted me with, "You need to pull yourself together." And she spat. And bang, I went again. And again, I staggered. I went to try and get help from the principal, who also screamed. I went back to the car. I found out on that day that 1 trauma event plus 1 trauma event does not equal 2. For me, it equaled 9. For about 9 months, Tim said to me, Tim would say, that's my husband, Tim would say, "Could you hand me the milk?" I could hear the words, but I could not understand them. I was really paranoid. So anyone that was looking at me, you were going to hurt me. I was so unhappy. And it was a wave. It was a tidal wave. Every single thing, everything that was around me, the weather, it's raining, it's against me. Everything was against me. I couldn't speak. I couldn't think. There was no hope. I was definitely never going to be able to go back to teaching. I couldn't leave the house, and I slept for hours and hours. My workplace immediately admitted liability, and all they wanted me to do was go back to work. We just want you to go back to work. We just want you to come back. They had absolutely no concept that number 1, I had been injured, and number 2, that there's actually a process to get back to work. They had absolutely no idea what to do, no idea how to support me, and for the entire duration of my injury, I had no contact with my colleagues who I'd worked with for 5 years. That's the crux of it. So I want to say one more thing, is that in the whole process, so the backwards and forwards, I just want to say this to the room, that many psychiatrists that I had to see said Jenny's mental illness is well managed and it has absolutely no impact on her ability to perform her job.
Thanks, Jen. There's so much in that. And I think what I'll do, Darren, is question to you. That experience of sort of trauma on top of mental illness is obviously had a very big impact on Jen. And could you just sort of talk to that a little in terms of understanding kind of from a, psychologist perspective, like what's happening there?
Okay, so I think we all sit on this mental health continuum and we quite often associate mental health with illness. but we should be talking about mental health as something that we can work on and build scaffolding around ourselves. And I don't think we do that particularly well, certainly in Australia, but globally as well, when we're seeing that the rates of mental health really escalate and go through the roof. And unfortunately, with trauma, the experience of adverse childhood experiences that we're learning so much more about can really impact and do impact people later in life. So some people, as in Jen's case, can be functioning relatively well, and there may be a trigger, i.e. the work situation, and all of a sudden, the way trauma works in your brain, it's like connected. There's all these connections, and then they can fire up, and you will regress back to those childhood experiences. And that's when it gets really, really challenging for people, because it's likened to open a Pandora's box in some respects. And in Jen's case, wasn't really aware of that particular trauma experiencing. Yeah. I think as a psychologist, it's good to hear that your psychiatrist did some great work in 6 weeks to get you back where you went back to work, first of all. I think that's amazing. But the other thing is that I think it's really important to understand that these things are treatable, okay? And EMDR, most of you, anyone familiar with EMDR? Yep, perfect. Anyone trained in EMDR? Oh, not so perfect. So EMDR, eye movement desensitisation reprocessing, is a really amazing treatment that they use for trauma, amongst other things. Very, very successful, and it enables you to process trauma really, really quickly. Foundation of all good psychological treatment, all good case management, all good employer relations is around empathy. And empathy, genuineness, and non-possessive warmth are 3 things that are vital to actually developing really, really good relationships with people. And from my experience working as a rehab consultant, managing hundreds of rehab consultants, and seeing people within this scheme, is we like to tell people what to do. I don't like being told what to do. How many people like being told what to do? Show of hands. You all like being told what to do you? I'm just not so sure about that. And I think sometimes we get into that mode instead of taking the time, in Jen's case, really to sit with that discomfort for a period of time. And we need to do that. We don't like that, but it's really important. And empathy drives connection. And if you're not connected, things just won't work.
Thank you. I think one of the things that we really wanted to sort of highlight in this discussion was that despite Jen's condition, she was very unwell and it was quite complex in a way to treat in terms of, the workplace relations, the prior history, all of those things. But fundamentally underneath that was someone who wanted to get better, who knew how to manage their mental health and actually wanted to return to work. And so what I'd like to do now is just sort of shift, because what we really want to do is talk to in a really practical way, like how did you get from that to then recovery? This story has a very happy ending. It's got a very positive ending, and I think that's as well something that we really wanted to highlight, is that people do recover from very complex psychological injuries, and getting people back to work and connecting them to work is just fundamentally critical to all of the work that we do. And so now if we sort of shift to what jumped out at you in terms of what worked really well in terms of your return to work processes and your recovery.
Thank you, Sharon. I'm actually going to mention a few companies, and I'm mentioning them because Altius and Allianz were the two people who helped, the two organisations that helped me return to work, and I want to talk to their systems. But in saying that, I've spoken to so many of you in the room, and I know that you all do things that are absolutely wonderful, and that's really what I want to highlight. I'm going to give you 4 points, and all 4 are related to an empathetic approach. I want to start with communication. So a lot of people talk about communication in the mental health space. Now, I know this is just a document that you're looking at from a long way away, but at the top of that document, there's a large bold heading, and it says Recovery at Workplace Plan number 6. Now, I could not think. So at every medical conference, I was handed this piece of paper, and at the top of it, it had the numbers, number 6, number 7. I knew that we were progressing. This document was so important to me because it's how I hung on to making progress. I couldn't understand what Allianz and Altius, I couldn't understand what the people were telling me at the time. I couldn't take in the words, and I didn't want the words because the words were, you're trying to attack me. So it was this document. So the big font at the top and the numbers all the time. The other thing that was fantastic is that there's a table on the inside. So it goes through the months and it says week 5, week 6, week 7, week 8, and it's a full table. And we would always be going from the week that we're in, so the top part of the table. When I looked at that, I knew that we were at this point and we were going to there. I could see it. I couldn't understand it. I couldn't read it, but I could see it. And that was really important. The other thing about this document was that every single person that was at those medical conferences was listed on this document every single time. Their name, their contact, who they were, and what they were doing at the next step. I couldn't, and I keep saying that, I could not understand the document, but the fact that it was consistent and it had 6 on it this time and 7 on it next time was absolutely essential. So that's the first bit. The written communication for me was far more important than the verbal, especially in the early stages. After every medical conference, which was in my GP's rooms, there were some people who were present and they would always sit beside me, and in the waiting room they would sit beside me. They would never sit face to face. That was really important. Don't sit face to face because you're going to attack me. And that's how I felt. The second thing is collaboration. I could tell that Allianz and Altius, I could tell that the two workers, they knew each other. They were on the same page. It's like parents when you have to talk to your kids. The husband and wife, you're together and you're like you're a force to be reckoned with. And that's what these two workers were like. They knew each other. They talked about different situations. They talked about things in relation to me, and they used gentle language. Proposed return to work. We will try this. There weren't words like, you will go back on this day. We're going to try sending you back 3 days a week. How does that sound? Gentle language. Also, at no time did any of these workers interfere with the treatment that I had previously been getting from my psychiatrist. They briefly spoke to him and then they left it alone. They didn't speak to him further, which protected that relationship. So that's number 2, the collaboration. There's one more thing on collaboration. They protected me from my hostile employer and they copped a lot of flack. The third thing is absolutely the verbal language which came later was totally non-judgmental. So if I said, I strained my groin muscles doing pole dancing, they would have said, okay. So there was absolutely no judgment whatsoever. And my last one is that it was pure facilitation. And I know many of you are facilitators, but with facilitation, I don't need to know the process, and I still don't know the process. All I needed to know was be at the doctor's at 9:30. I'll be there. Allianz will be on the phone. Altius they'll be coming to meet you. I didn't need all this is why we do this, this is, I didn't need that. I didn't even need to know we're going to do this every month for the next 2 years. I didn't need to know that. I just needed the information at the time. Use as few words as possible. Just tell me 9:30 here, tell Tim, and we'll be there. So pure facilitation, and it was guided the whole time by me. There were times when I would go to both of the Altius workers. There were times I'd go, hi, I'm really feeling good this week, and we'd talk a few things. And there were other times when she walked in that literally I was like, oh, and I'd be moving over near Tim, and I'd be like, just don't even look at me. And she knew, she read my emotions, and she supported me. So that's really my 4 tips. Thank you.
Thanks, Jen. Darren, to you, from a rehab, return to work, psychologist perspective, what does good look like when it comes to an empathetic approach, and what do you think are some of the kind of key? I know that's a really big question, but
it is a big question, Shaz. Thanks for that. So what does good look like? First of all, some key things that I would reflect on in Jen's story, which we kind of know intellectually that we should be actually doing these. It's actually putting it into practice. And I think with psychological claims, people are uncertain as to how to have conversations. How do I approach that? How do I actually talk about that? And we see that in terms of within Australia, 1 in 2 people suffering mental health are still not actually reaching out for assistance. So there's still a lot of stigma there. I think what I really liked about your story, Jen, was that to me, good rehab is a dance, right? And the rehab consultant is the lead, but you're taking the person with you through that gentle dance. Not pole dancing, Jen, by the way. That's a different story. And my supervisor, I can still hear his words ringing in my ears, said, make haste slowly. And I think what we see within the workers' comp context is really rushing things, which might work well for a physical injury where there's set times and but psychologically, doing the dance and bringing someone along for the journey and asking what you need, And too often we hear, oh, so-and-so's unmotivated. Well, they're not unmotivated, they're just motivated for different things. And going back to the essence of good communication and empathy, what is motivating that person? Understanding that, and without that connection, you just can't do it. So I think a lot of us think we're great listeners, but for the most part, we're actually pretty poor. We derail, we question, we don't listen, we're uncomfortable with silence, and you need to bring all these things together so that in Jen's situation and others, you're bringing people gently along for the journey and anchoring it in really good documentation. And I really like that you saw progress, albeit very small, but you were progressing. And when you're in the depths of a mental health episode, even the smallest bit is really, really encouraging, because people get into a really dark situation where they don't see any opportunities moving forward.
I think those points around, as you've talked about, sitting beside you, building that trust, What would you say, Jen, in terms of, you know, how did it work in terms of your belief to return to work? Did you ever lose sight of that? Was that something that, you know, they had to really kind of work with you, that was possible? With, you know, how could you just? I know I'm putting you on the spot a bit there.
No. Yeah, that's a tricky one. All I wanted to do was be a teacher. All I wanted to do was go back to the students. That's all I wanted. My employer, the only option was to go back to the same staff room. I could not be transferred. I had to go back to the same place. The employer said they would not agree to the conditions of the return to work. So the conditions were that they had to confirm or say that this person would not be allowed to scream again. It actually wasn't the screaming, it was the shaking. It was the out of control part, that she was not allowed to do that. But the workplace wouldn't do that because they said we have a code of conduct, and the code of conduct protects you and it protects your manager. So because that couldn't be breached, it was actually the two workers, so it was Allianz and Altius, that actually started to suggest, well, maybe you need to do something else. And I thought, oh, well, this is all I've wanted to do since I was 5. And they sort of just kept suggesting it, and then I fell into PIEF. I fell into this space, and I realised that if I actually have the courage, if I actually share the story, it can help lots of other people, and I can actually help the kids within the school. So I did go back to work. I went back to that workplace for 6 months, and I endured it in that staff room. And then I went back for the first 2 days of the following year, and I delivered my computer and keys, and that's probably the hardest handover I've ever done. But I have helped people over this year, and so it feels like the right thing to do. Yeah.
You ultimately made the decision to move on on your terms. Yes. Yeah. Okay. So much that we could sort of talk to for that. I think just in terms of, you know, if for the people in the room, if you could kind of give them one or two, you know, kind of key takeaways to hang on to when it comes to supporting someone with a psychological claim, how would you summarise that?
That's what I needed on that day. That original day was really simple. So I just needed someone to stay with me. I didn't need them to talk. I just needed them to stand next to me, and we needed to walk. And if once I started to calm down, if they could just say, you know, you're safe, where can, you know, what can we do for you now so that you feel safe? They didn't have to fix me. They didn't have to diagnose me. All they had to do was stand next to me. The fact that they didn't caused a lot of damage for me, because there were more memories that came out as I headed to the car. I would say that if you see someone who's had an emotional response, just say to them, would you like to walk with me? That's what I would say. And I would say just walk, let them talk. If they want to, be silent, like Darren said, be silent, but just walk next to them, let them calm themselves down. And it's actually our biology. So if we're together, our brains are trained to actually co-regulate. So it's actually in our biology. That's what I would say. And in your professional spaces, I'd just say think about, if with a psychological claim, think about what it would be like to spend your life inside one of those blow-up balls that's in amusement parks that people get in and they run around. That's what it feels like. So speaking, seeing, all those things are muffled. So if you think about the plastic balls, that's who you're dealing with, someone that's stuck inside one of those and they're on fire.
Thank you. Darren, any other kind of key takeaway points, just sort of to wrap up in terms of, you know, psych claims to this?
Yeah, I think so. I think, again, Jen's situation, whilst distressing, there's some amazing things happening. And first of all, everyone was on the same page, which quite often is quite challenging within the workers' comp context, where you've got practitioners pulling in all sorts of directions. And I think the fact that they were openly communicating with one another is really, really important. It's best practice. We talk about it a lot. We come to conferences all the time and hear the same stuff being talked about. And yet, sometimes when I'm reviewing a psych claim and someone's had 100 sessions of psychotherapy, no treatment goal, no measurement, what's going on? It's ridiculous. And the person who suffers is the injured party. The other thing I think that's really important is just your language when you're talking to someone is really, really powerful. And Nguyen, in his kind introduction, mentioned, I've got a diploma in clinical hypnotherapy. And after working as a psych for 20 odd years, I learnt how powerful language is via hypnotherapy and the suggestibility of language and what you actually say. So be really mindful of messages that you might unbeknownst convey to an injured worker and the impact of your language on that person. It's very, very powerful.
Thank you. I think we do need to wrap it up there. We could literally talk about this probably for a couple of hours, but I think I just wanted to, full credit to you, Jen, sharing your story, the bravery. Jen and I actually crossed paths at PIEF about 4 years ago when she came up to me and she said, I just wanted to let you know about the great rehab that we had, and sort of that has developed over the years into lots of conversations. So I think what's really incredible and admirable is just knowing that, people can recover from really significant injuries. Often when we are working with people who are, very unwell or have been unfit for some time, and there are lots of complexity around the claim, I think it's important that we don't give up on those people. It's really important because we are the ones who are responsible to, whatever our roles are in this ecosystem, to support them to return to work and to return to a productive life, an engaging life, whether that's work, whether it's family, all of the things. Work is part of your life. You're also a mother, a wife, all of the other things. You're an excellent wife. Let's just ask him. Look, thanks so much for your time, and enjoy the rest of the day.
Just the 6 things that I would like people to know about mental health and a bit about big empathy. I just wanted to say there is
if you're at the back, I might get you to come up the front because we are going to do a little bit of a game on the screens via the QR code. So come in and come up the front. Don't be shy. We're just finishing setting up. Come in. Red flags in opioid. Come in, come up the front. Excellent. All right. Come in, everyone. Okay. So we might kick off just to make sure that we're keeping to time. So welcome to the session on seeing the red flags, identifying medication risks in injury claims. My name is Angela Sormaz. I'm from the TAC and I'm the Senior Manager of Partnerships and Service Delivery. This session today is part of the issues stream sponsored by CERA, and a reminder that the Q&A is through the web-based app. So please chuck all your questions on there, and there'll be time at the end to ask those questions and hear the answers. So without further ado, I would like to introduce Jenan and Ezra from MEDEX to start the presentation.
Thank you, Angela. If you guys want to scan the QR code, it's going to be like a Kahoot session, so a game session. We're trying to make it as interactive as possible. And can you see the game pin over there? 605. Sorry, 6015. 718. So good morning, everyone, and welcome to the Red Flags workshop, and thank you for choosing to join us today. I know there's a lot of amazing sessions, and we're very grateful that you're here. So my name is Jenan, and this is Ezra. We are the co-founders and consultant pharmacists here at MEDEX, and we hope you find today's session practical and hopefully interactive. So over the next 30 minutes, Ezra and I will walk you through some case examples, and we'll use this Kahoot platform to get your input along the way. So have your phones ready to participate. So Ezra and I, we work alongside claims managers across different schemes every day to provide independent advice on medication use. And we hope by end of today you can see that you don't need to be a clinician or a pharmacist to identify and spot some medication red flags. And with the right tools, anyone involved in a claim can recognise when something doesn't add up. And often that is what is needed to be the first step in identifying those issues and improving outcomes for the claimant. So the learning objectives for today, we hope... Can I get that one? Hard to stand there. Okay, so by the end of today, we hope that you'll be able to identify how medication use can potentially delay recovery and contribute to claim complexity and add further liability to a claim, and recognise some common medication red flags and know when to escalate for a medication review or to seek further clarification. So before we dive in, let's get a show of who's in the room. We'd like to get to know you. So if you can, which area best describes your professional background? If you can fill that in. 6015 718. Thank you. Okay, looks like most of us are within the insurance sector. We've got a bit of a mix, healthcare and other. That's what we like to see. So great blend of people today. That's perfect because each of you plays a vital role in picking up on red flags, especially when it comes to medication use on claims. So are medications really that evil? We'll start with a controversial question. Are medications evil? Do they cause more harm than good? Or do you think they're life-saving tools? Does it depend on how they're used? Or are you just here for the Kahoots? That's right. So it does depend on how the medications are used. So of course, there are some life-saving medications, and we're grateful for those, but depending on how the medications are used, they can sometimes pose more risk than good. Okay, a final poll before I hand over to Ezra. How confident do you feel interpreting medication use on a claim? Are you very confident, somewhat confident, unsure, or not confident at all? No judgment. We're just here to see who's in the room and see how we can help assist you with practical tools moving forward. Okay, so we have very confident and somewhat confident. Majority, 13% are not confident at all. That's fine. As we said, that you don't need to be a clinician or a pharmacist to pick up on some red flags, and we'll talk you through some real life case examples to help you identify some of those. I'll hand over to Ezra and I'll come back towards the end. Thank you.
All right, good morning everyone. So I'm Ezra. Let's jump straight into some case studies. All right, so we'll walk you through some de-identified examples of some cases that we've actually worked through and how we identified the red flags in each one of them. And, as I'm speaking, if anyone's got any questions, feel free to ask or interrupt at any time. Let's start with John. He's a 45-year-old truck driver who injured himself at work as he was coming out of his truck. He underwent surgery for his injury, and he also underwent 2 years of intensive rehab. And he's still complaining of significant pain, and he's unable to work because he's just generally not feeling well. Now, John's also been prescribed some medications. So some of the medications that he's been on are opioids. We all know what they are, sometimes known as painkillers. They reduce pain by 30% at most. They're not really recommended for long-term use as per best practice guidelines, and they do come with a whole host of issues like cognitive side effects and physical deconditioning and whatnot. He's also been prescribed an antidepressant for his nerve pain. He's been prescribed Valium to target his muscle spasms, and he's also on an anti-inflammatory medication. So despite all this cocktail, he's not feeling well, and his case manager was lost, so she didn't really know what to do. So does this sound like a familiar case at all? I can see someone nodding, so let's take a quiz. So referring to John's case, what do you think, if you were the case manager, would be the most appropriate next step regarding his recovery? Would you escalate it to your team leader, start a conversation with the treating GP, refer him for a medication review, or are all of the above options suitable? All right, so it looks like most people have selected all of the above, and which is great because all these options are actually quite suitable to take. Now, in this particular case, the claims manager decided to refer John for a medication review. So let's see what happened next. All right, we've got a scoreboard here. Who's I love PIEF? Okay. All right, so with John's case, we conducted a medication review, and in the review, we identified that he was on a really high dose of opioids and Valium. He was in fact taking more than what he was being prescribed. At that stage, he reported that he was feeling tired, he was sedated, he had low motivation in general, and that was impacting on his ability to engage in rehab, and he wasn't even thinking of work at that time. Now, at that particular stage, the GP had just continued prescribing, so it was more symptom management than actually helping him functionally get better, and there was really no functional goal or no end in sight. So after extensive discussions with his GP and of course further support from his insurer as well, we managed to reduce his opioid use. So he was placed on a wean and cease plan, a very slow one as well, considering the length of time that he was prescribed these medications. And over time, his dose of the medications reduced and his cognitive abilities slowly started to improve. And I guess that's an example of addressing one return to work barrier. So the medications were no longer considered an issue for him at that stage, because then he was just rationalised on the anti-inflammatory as required. So this is not actually an isolated case. multiple studies have actually shown that opioids are associated with longer time off work. We've referenced this study here conducted by Michael Di Donato, which looked at workers within the Australian Workers' Compensation Scheme from South Australia and Victoria. So this was a retrospective study which looked at almost 10,000 workers, and in that study they found that workers who were not prescribed opioids as part of their injury, it took them about 7 weeks to get back to work, whereas those who were prescribed opioids had a median return to work of 126 weeks. So as you can see, that's over 2 years of time off work simply because medications are being mismanaged. And it's not just any medications with limited evidence to support any sort of return to work. So it's not that the opioids are bad, they do have a place in therapy, but when their use continues, it does go against guidelines. So why might workers on opioids take longer to return to work? Is it the side effects that we've discussed, the risks of dependence and withdrawal, the loss of physical conditioning and confidence, or all of the above? That's great. Looks like everyone's on the right track. Everyone's been listening. So it is a combination of all of the above. We've got a scoreboard here. I love PIEF is still in the lead. All right, so let's move on to medicinal cannabis. So we've looked at opioids that are familiar. Medicinal cannabis is a relatively new entrant to the pain relief party. It was legalised in Australia not too long ago, and since then prescriptions have now surpassed 1 million. It's become big business here. Businesses are advertising it as plant-based or natural medicine, just to bypass strict TGA regulations and laws. The Australian medicinal cannabis market is now probably one of the most lucrative in the world, leading some to describe it as akin to the tobacco and the alcohol industries. So lots of issues there. One of the main issues, I guess, is the online prescribing platforms that are currently, rampant. So people can simply log in, see a doctor online who they've never met before and get a prescription for a highly addictive Schedule 8 medication. Right, so medicinal cannabis. There's always a misconception that it's safe because it's natural. Would everyone here agree that that's true or false? Okay, great. We're all on the right page. So let's see what happens when we've got medicinal cannabis on a claim. So just to see where everyone is at the moment, if you were a claims manager and you received a request for medicinal cannabis, what do you believe should happen next? Should this request be approved? Should you request further supporting evidence, check medication suitability yourself, or deny the request altogether? All right, brilliant. So everyone is requesting further supporting evidence, which is great. So let's have a look at our next case study. Let's meet Jason. So Jason also injured himself at work, and he sought medicinal cannabis 6 weeks after his injury to manage what he believed was his chronic pain. So Jason hadn't adequately trialled any first-line therapies, and what he did was he jumped onto online social media platforms like Reddit, where everyone was discussing the use of medicinal cannabis. He was quite intrigued, so he booked a consultation with an online clinic who then prescribed medicinal cannabis for him. Now, after he did that, he of course went to his insurer and sought reimbursement for the medication from the insurer. So the medication that he was seeking reimbursement for was a THC flower, so that would be vaporized and inhaled. Now, looking at Jason's case, what stands out as the main red flag? Is it that the request occurred only 6 weeks after the injury, that he says cannabis is the only thing that works for him, or there are no red flags and because cannabis is considered organic? just a little slow. All right, both of these could actually be correct options. The request was in fact made too early, and he said it's the only thing that works, which is a big red flag, and that's what caused the case manager to refer this case for a medication review as well. So really, timing here is a major factor, because we should really be asking further questions, and that's exactly what happened. So we reviewed Jason's case, his medication history, and his injury timeline. And what immediately stood out was that first-line treatments hadn't adequately been trialled at that stage. His injury was only 6 weeks old, which meant that his pain couldn't actually be classified as chronic. And most importantly, his GP wasn't actually aware of his use of medicinal cannabis, and nor was he supportive of it. And I guess one of the major things in the background was Jason had an underlying mental health condition. He had schizophrenia and was on medication for that as well. And THC and schizophrenia could probably be one of the worst combinations that anyone could potentially be on. So this raised several red flags. The first, obviously, cannabis is not a first-line treatment. THC itself is associated with risks, the cognitive side effects like sedation. It can lead to dependence, and it can also aggravate underlying or unstable mental health issues, and many safety-sensitive roles, so like Jason's one, would actually prohibit the use of THC, and of course driving is illegal. So by summarising all these steps, the discussion with the GP shifted to, what is the next appropriate step in recovery.
Thanks, Esra. We just have 2 case examples left before we wrap up. So let's have a look at Alexa's case, one I'm sure many of you will find familiar if you work in claims management. So Alexa reports gaining 12 kilos since her injury and requests Mounjaro. Mounjaro is an injection. It's typically used for type 2 diabetes, but it's become increasingly popular, especially for weight loss in overweight or obese people. So in this case, Alexa attributes her weight gain to pain medication side effects. She's saying it's because of her pain medication that she's put on the 12 kilos, and her GP supports this request. And at first glance, it might seem like a straightforward situation. You know, she took a claim-related pain medication and now it's contributed to weight gain, and therefore the insurer is liable for the secondary weight gain situation, and they should approve Mounjaro. But as we'll see shortly, there's a bit more to it when you look deeper. Okay. Just take a hoot for you. So what do you think is the main concern with approving Mounjaro in this case? Do you think it's a cost issue? Do you think Mounjaro is not suitable for weight loss? Are there multiple causes of weight gain that should be investigated further, or no issues at all? Okay. So everyone's put multiple causes of weight gain, which is correct, because weight gain is multifactorial, and it's important that the GP investigate those potential causes, as we'll see what happened in the actual medication review for this one. So here's the leaderboard. HP is on fire. Okay, so what happened next? The pharmacist conducted a medication review, and what we found, or what the pharmacist found, was that the patient actually had bipolar disorder and was being treated with an antipsychotic, which is typically known to cause weight gain. The patient also has hypothyroidism, so it slows down metabolic function and can be associated with weight gain, especially if it's not well controlled. And there were no recent blood tests, so the GP couldn't confirm if the hypothyroidism was well controlled. What happened from this medication review was the GP referred Alexa to endocrinologist and referred for some bloods as well to investigate the underlying cause of the weight gain. So what this case shows is that the medication review actually shifted the focus. Instead of it just being about adding a new medication like Mounjaro, we're helping uncover the real underlying issues which can lead to better outcomes for the injured person. Okay, this is our last example. This is Jane. So Jane reports dental decay secondary to her antidepressant. She was taking an antidepressant which is typically associated with dry mouth, it's NDEP, and her dentist supports this, noting the dry mouth as a side effect of the medication and therefore contributed to her dental decay, and gave her a dental treatment plan of $6,700, which Jane then forwards on to her insurer because the medication she's citing, NDEP, is a claim-related medication. So naturally she thinks it's a claim insurer's responsibility. So let's have a look what we discovered with this claim. So on the surface, it seems quite simple, right? You know, a clear cause and effect like our previous one. But as we've seen in all our other cases, there's always something going on behind the scenes. So imagine you're on the claims and clinical review team. What do you think you would do next? Would you approve the claim, dental claim, medication likely caused the problem? Would you review other potential contributing factors? Would you ask the GP to stop the medication immediately, or would you ignore the request? That's right. So before making assumptions, it's important that we take that step back and look at the full picture. So let's see what actually happened when this case was referred for a pharmacist review. Okay. So once the pharmacist reviewed the case, things started to look a little different. The antidepressant in question had only been used for 2 weeks and then stopped, so it was actually unlikely to be the significant cause of the dental issues reported. What we discovered was that there were other significant risk factors in this case. There was long-term smoking, poorly controlled diabetes, and reflux, all of which can contribute to dental decay and dental damage, and in combination, they're far more likely explanations than a short-term trial of medication. So let's test what you've taken away from this. What becomes clear once we review the whole picture? Okay. Was it the dentist's concern was unfounded? Was it completely valid? Was the antidepressant that was used for 2 weeks likely to be the main cause of decay, or were there several other valid health factors that must be considered? That's right, yep. So there were several factors that must be considered instead of just assuming that it's the medication that was the culprit in this case. Okay. Okay, so before we wrap up, let's have a look at what we've learnt today. Okay, so we know that medications, it's rarely black and white. We need to look beyond the simple cause and effect assumptions, and if something doesn't add up, whether it's unexplained side effects or minimal progress on the claim, that's a red flag worth exploring. And medications can sometimes actually hinder return to work, and depending on how they're used. It's not just injury-related medications we need to look at, it's also the non-injury medications that we have noticed can cause an impact on return to work, and also lifestyle factors. The key takeaway is if something feels off, it probably is, and that's your cue to dig deeper or refer for review. To finish off, we just have 2 questions left. So what do you think is the main goal when reviewing medication use in compensable claims? Is it to reduce overall medication cost? Is it to identify blame or non-compliance? Is it to support safe recovery and function, or do you just disregard medications? Okay, it's taking a bit long, but yes, it's not about cost cutting or blame, it's about supporting the safe recovery and reducing overall risk. Okay. Last question for today. So which situation do you think should prompt a closer look at medication use? Is it an early request for medicinal cannabis, multiple medications used, medications blamed without evidence, or all of the above? That's right. So these examples we've come across, Ezra and I talked you through examples of early requests for medicinal cannabis and why that's problematic. It means a person hasn't adequately trialled first-line treatment options. Multiple medication use increases risk of side effects, increases risk of, medication side effects and issues, and also usually multiple medications means sometimes multiple prescribers, some extra specialists, so miscommunication between them can actually happen, and medication blamed without evidence needs further investigation. Okay, do you have any questions? I think we have some here.
I'll let you keep that and I'll just talk into
Oh,
this.
yeah,
Is that
sure.
all right? Sorry, thank you so much for... there we go, we're on now. I think, we're on. Yeah, thank you so much for a really interactive presentation. Loved the use of the Kahoot. Bit of healthy competition never goes astray. So well done on whoever ended up on top of the scoreboard there. Please submit any questions that you've got through the app. But there is one here. How does MedX work with insurers for medication reviews? Do you work with treaters to influence prescribing?
Yes, we receive referrals directly from case managers, and we do work with treaters to influence prescribing. So that's pretty much the gist of it.
Yeah, so sometimes we speak directly to GPs, specialists, with the injured workers at times as well, and we devise a medication management plan and that helps case managers, I guess, know how to progress that claim.
Great, thank you. There's been no other questions come through the app. Does anyone? Yep. Do you want to? Ah, that's all right. I'll just come over. I have to bring the mic to you because just for the people online, so I'll just do a bit of roaming mic.
Thank you. I just had a question. So, as an employer, as a return to work coordinator, I think having conversations around medication, particularly with doctors, can be really tricky because you get worried that you don't want them to think that you're undermining them and they're meant to be the expert. So, do you have any tips for how, if you're in a review with a worker, or even if you are wanting to sort of put together your own, not necessarily a medication review, but question the medication? Do you have any tips for how an employer or return to work coordinator can do that in a really respectful but impactful way?
Yeah, look, absolutely. I think the first thing that some workers get worried about, especially if they're on opioids, is they automatically assume that, the medication review, for example, is going to result in their treatment being withheld or the insurer, just declining any further requests. So it's all about the case manager, before making the referral, openly communicating with the worker and letting them know that, look, it's just a part of the process to ensure that you're on the best combination of medications to get better and to help you achieve your goals. As soon as they understand that, the review is not there to decline certain medications, or, it's not an adversarial process, then they're usually pretty good. That's in terms of the workers. With the GPs, we've personally not had any issues with them. They're kind of used to a collaborative approach, when it comes to prescribing. Of course, that depends on the conversation and the way that the questions are asked, and it's all about working together. And, if the recommendations come and if recommendations are made that are in the best interest of their patients, and there really is no problem why they would be hostile to any recommendations or any suggestions made. So just open communication with them and making sure everyone's on board, everyone's aware, and that's the best approach that works.
Thank you. And there is one more that's come through the app. So generally, how far into a claim is a medication review appropriate?
I would say at any stage, the earlier the better, especially if there are opioids, because typically what happens is their use does tend to escalate. For example, they're generally not recommended for 12 weeks for use 12 weeks beyond and beyond. However, I would go a step further and say they're probably not recommended beyond 6 to 8 weeks. There really is no reason why someone should be using them that long. So as soon as you see them, it's best to catch them early on. It's the opioids and the benzodiazepines, so the sedatives like the Valium, the Xanax, which you probably wouldn't see much of these days because it's so heavily regulated. But they're the two main groups that should really be addressed very early on.
Just regarding that question, it also, so let's say months or years down the track, if you see someone on multiple medications like opioids, painkillers, but they're still reporting pain, that's also worth referring, because sometimes that means the person has now become so dependent on the opioid medication, the opioids are no longer working effectively, but they can still cause side effects, and they can still cause side effects down the track. So a medication review months, years later, if someone's on medications and still reporting suboptimal response, that's also worth investigating.
Also, anyone who's in a safety critical role as well. It's good to know what exactly they're taking. We did have a slide that I think we removed from the presentation about the Hunter Valley bus crash that happened a few years ago. The driver in that case was on the opioid tramadol after a workers' compensation claim in the 90s. So we can see how devastating that can be, not just for the driver themselves, but for the 13 others that unfortunately lost their lives too.
Thank you very much for answering the questions and for your presentation. Please join me in giving a big round of applause to Jenan and Ezra.
Good morning, everybody. Welcome to your next session for day 2. My name is Nathan Harcher. I'm the Executive Manager for Small to Medium Employers at Suncorp GIO. The session today is Human Insights Digital Tools, redesigning systems for better outcomes. This is a part of the Innovator series, so it is a Q&A. If you open up your app, I'm sure you're all well aware now, you can lodge a question and we can have time at the end. We have 5 now presenters. We have Brana Godich from the University of Melbourne, Michael Di Donato from Monash University, Hugh Seawood. We also have Thea Hobbins from Allianz and Dr. Angie Montgomery. If I could please have Brana Godich to the stage first. We'll have a 15-minute presentation from 3 different groups, and then we'll have 15 minutes for questions at the end. Thank you.
Good morning, everyone. Good morning, everyone. So my name's Brana. Sorry, technical difficulties to start with. Mic's down, great. Am I good now? Okay, thanks everyone. So great start from me, appreciate it. So I will be talking to you today about a project called the Workers' Voice Project. This project is aiming to understand the perspectives of lived experience advisors. Still can't hear me? Okay, how about now? I think I'm going to stand right here. Okay, I'll do that. So this project is aiming to understand the perspectives of people with lived experience who have gone through injury compensation systems and basically using their insights to try and gather policy ideas and putting them into computer models to test them. And so when I've given this talk before, and I've honestly had technical difficulties every single time I've started this talk, so when I've given this talk before, I usually have to explain to people what workers' compensation is. So please forgive me telling you things that you absolutely already know at the start. So as you know, roughly 500,000 people every year will have a workplace injury, and not all of these people will have to have a workers' compensation claim. But for the people that do, people have different experiences going through workers' compensation systems. So some people have a really good time. They will just go through, they will report positive experiences, experience recovery through a set period of time, and will be able to successfully return to work either with the same employer or a different employer. But unfortunately, as we know, not everyone has... I'm pressing the green button, I swear. Oh, okay. Okay. I think I'm just going to struggle each time and then we'll hopefully figure something out. But unfortunately, not everyone has a positive experience going through the schemes. So as we know, some people find them incredibly stressful. They will have negative impacts upon their interpersonal relationships, financial consequences, employment-related consequences, and the development sometimes of secondary psychological injuries as well. And so to understand further insights, now let's see how this is going to go. No, that's the pointer. Here we go. And so to understand the experiences further of people who have gone through workers' compensation schemes, we first started out by speaking to as many injured workers as we could. And so after speaking to injured workers, what we then want to try and do, so this is the first half of the project, is to try and speak to people, and the second half of the project is to put their insights into a computer model, but I'll come to that shortly. And so when we were trying to understand the perspectives of people who have gone through workers' compensation systems, like I said, we tried to speak to as many as we could. So we started out by surveying injured workers, and then injured workers who selected to were invited back to participate in further in-depth interviews and focus groups. And so the results that I'm going to show you now are some of the quotes from people who have gone through the schemes describing what the experience was like. So for some people, it looked a bit like this.
So they described it as a maze that they sort of were standing at, and they found it very, very difficult to navigate. And the following quotes are direct quotes from participants who we spoke to as part of the study. People described it as impacting their whole lives. Some people, forgive the language, found that they felt completely screwed. People described developing complex trauma and experiencing isolation. They felt broken in many different ways, not just physically, but mentally and emotionally. They found it very confusing, so no one telling them, in some cases, what actually happens as part of this game. Feelings of powerlessness, and some people claimed that they were warned in advance about what the system was like before they went into it. So understanding these insights gives us a further motive, I guess, into trying to understand how the system looks at the moment before we can try and use the perspectives of people who have gone through it for policy insights. So we effectively ask them, okay, this is your experience. What could we then do differently? What are your ideas of how the system could be reformed? And so to do this, we then had to build a model of the current state of the workers' compensation system. And so understanding that building these kinds of models, we need to consider not only the workers' perspectives, but the insurers as well. So we need to consider the fact that insurers also have constraints within which they have to operate. So they must be financially responsible as probably one of the most, if not the most important consideration. They must maintain client satisfaction and also actually encourage and make sure that people return to work. And so when we are building these models, we're building them not only from the scheme level, but from the individual level as well. And so to do that, we've used two different modelling approaches. To inform our models of how things actually work was probably one of the biggest challenges that we faced in the early stages. And so we tried to gather as much information as we could about how the schemes work. We tried to canvass a really broad range of information, so looking at insurer and regulator resources that were publicly available. So some of this is also recognising that this is only what's published, so there's also a lot of tacit knowledge out there as well. There's academic literature that we considered as well, so as much as we could find. Yeah, I can hear the vibrating as well. And we also spoke to experts, including a wide range of domain experts and lived experience advisors that worked with us as well on the project. So the first, keep going, okay. Great, okay. So the first method that we used was called system dynamics modelling. And so this method allowed us to capture the whole state of the scheme as it functions. And when I talk about the scheme, what we tried to build was something that was as generic as it could be. So this does mean that we lose some of the specific richness of workers' compensation schemes in terms of the different states, but we wanted to try and build a generic model. And so the modelling approach that we used allows us to do this. And the system dynamics modelling is kind of what's in the name. So it allows us to capture the dynamics of systems. And so what it allows is to represent a scheme or a system and the way that parts flow from one location to another location and then looking at the factors that affect that. So as you can see in this diagram, we've got things going from somewhere to somewhere else affected by particular rates. So for example, you could have a certain number of claims that need to be processed and then the factors that would affect processing rates as a very simplified sort of example. And so the image that I'm going to show you next is the most simplified version of a whole scheme that we could have developed. And it looks like this. So nice and simple. So what we have here is an end-to-end representation. I'm not going to go into this in detail for obvious reasons, but I'm happy to take questions on it. So what we have here is an end-to-end representation of a generic workers' compensation scheme. So on the left, I know it's really hard to read, I apologise for that, but it's impossible to read in fact. But what we have from the left is the inflow, so people coming into the workers' compensation scheme. Then we've got some provisional services being rendered. Then we've got claims assessment. Then we've got services being provided and people leaving the scheme, and in whichever way, whether that be return to work or through or other outcomes. We've also got parallel processes that, again, can't be seen here, but for return to work and also disputes. And please keep in mind as well that this model is not just the model that you see here, it is many layers deep as well. So that's the simplest representation that we could put together for the whole of the scheme. But in addition to looking at the whole of the scheme, we also tried to look at individual people's experiences. And so for that, we needed a different kind of method. And the method that we used is called agent-based modelling. Agent-based modelling, in brief, allows us to try and build a simulated virtual environment that has different kinds of agents. And now when I say agent, I don't specifically mean a claims agent, I just mean a decision-making entity. So this can be any kind of individual, an injured worker, it can be a claims manager or a claims agent, IMEs, GPs, doctors, anyone that has decision-making capabilities is considered an agent in agent-based modelling. So in agent-based modelling, we can set up these individuals, they can interact with each other, they can learn from each other, learn from their environment, and essentially we can just kind of let them loose based on predefined rules and see what happens. And so we can look at the emergent phenomena that come out of that. And so to do that, this is a really good approach, both this one and system dynamics, for testing different policies. So in addition to setting things up, we can then implement different policies and look at their outcomes. And so the ABM that we're building at the moment is developed to try and capture the injured worker's experience. And at the moment, because this model is quite complicated, so I showed you the system dynamics model. The model that we're building for the ABM is currently about 1,000 lines of code, so I'm going to give you a very simplified overview of the kind of rules that we have implemented in the following few slides. And for the following few slides, I also apologise. It's gone against almost all of my moral and ethical principles to have this many emojis in a presentation, so please bear with me. But some of the very simplified rules and processes that we can have in these kinds of models are as follows. So for example, we have our injured workers. Our injured workers will have a suite of characteristics that we deem to be important. So they can have age, gender, they can have obviously an injury type, injury severity, and a broad range of additional characteristics that we can attribute to them. So after that, once they have, but in the model, they start out with an injury. They then go and see a medical practitioner who will consider whether their injury is work-related or not, and they will either have this sort of considered as work-related or not by the medical practitioner, who will then provide them with some sort of documentation to this effect. This documentation will then be submitted to a claims manager along with additional documentation, who will then consider the claim based on a number of different factors. So one of which is the injury type, another is disposition, claim load or workload rather, complexity of the claim, and whether additional information is required. So for example, sourcing additional information from IMEs or similar. After considering all of these different factors and more, the claims manager will then either approve or deny the claim. If the claim is approved, people can start receiving services, either financial and medical or medical only, with the hopes that their trajectory and recovery improves. However, we can also capture some of the elements of complexity that don't lead to straightforward and linear recovery pathways, including delays. So for example, workload-related delays, lack of clarity, and difficulties surrounding access to different, particularly medical services. And so when we look at building these models, we also need to consider the outputs of them. So the outputs can be at two different levels, because as I mentioned, we're focusing on both the individual and scheme level, and so that's what our results are as well. So our results for the individual level are focused on primarily stories. When we consider stories, we consider the story of an individual through each step or each time step of the model. So at each time step, we can track different features, including, but not limited to, claim status and type, the kinds of services and number of services that they've received, their current scores, so work capacity and mental health, satisfaction with the scheme, and claim duration, just as some of them. And so when we track these features over time, what we can eventually put together after a certain number of time steps is something like this. So please keep in mind these numbers are not to be taken literally. They're sort of just they're abstract representations that are indicating someone's status at any particular time. But we can have, for example, a random client who is generated who has a particular work capacity that's very low at the start. Again, please don't take that number literally. And then eventually, after receiving services that sort of take a little bit of time to come through, they experience a fairly good recovery and recovery in terms of their satisfaction with the scheme as well. So these are the kinds of stories. This is just one story. In the model, we can have thousands of agents. So we can look at thousands of stories of people having gone through the schemes. In addition to that, we can also look at scheme level outcomes. So we can look at things from a broader perspective as well, in terms of the number of approved claims, current average work capacity of people within the scheme, client satisfaction, processing times, service requests, unfulfilled service requests, and service request timers as well. These numbers are not to be taken literally because the model is still in development. They takes a little bit of time to build, but these are the kinds of outputs that we'll be able to look at. So the point of showing these kinds of representations is that once we understand the scheme as it is, we can then put in different policy ideas and compare the outputs. So as I draw to sort of the end of a presentation, again, apologies for technical difficulties, one of the critiques that sometimes comes through of modelling and these kinds of approaches is that it can seem kind of impersonal in terms of trying to put sort of these rules and these experiences into a computer. But when we were doing the validation for the first model that I showed you, we showed our lived experience advisors, so people who had gone through their workers' compensation scheme. And when I was showing them each stage of the model and just checking with them, is this sort of your experience? Is this your understanding? I wasn't sure what kind of reaction I would get. I wasn't sure how that would go. But this is a feedback that we received essentially from this person who apparently was quite happy with the model, which was good. But showed us that we were able to capture quite a few elements of the different aspects of the workers' compensation scheme as well, which was good. And my final takeaways is that, so what we're trying to do at the moment is build the current state of the workers' compensation scheme, or a generic workers' compensation scheme, from both individual and scheme level perspectives. It's been co-designed with people who have gone through the scheme. And the next steps of the model are to try and use their ideas of people who have gone through the schemes to try and generate policies, ideas, implement the policy ideas into the model, and then look at the outcomes. So these are my acknowledgements, and this is funded by Australian Research Council Discovery Grant. Thank you.
Thanks, Brana. I'm not going to move the microphone because I don't want to add to the technical difficulties here. But our next speakers are Michael D. Donato and Hugh Seawood. If you could come to the stage, please, and take the microphone. It was remiss of me not to mention that GIO is in fact the sponsor, my employer, at the start of this. So please don't hold that against me. And just a reminder that we do have the Q&A, so keep those questions flowing through. Thank you.
Thank you, everybody, for attending this morning. So the schemes have a problem. They have a problem with compensable medicine. And the problem is mentioned here. The problem is the deficiencies amongst those primary healthcare providers who are providing care to those who are caught with a compensable injury. And we know that those deficiencies they hinder recovery, they slow return to work, and of course they increase costs. And we've heard quite a bit about this discussed, particularly yesterday, with Tanya and Mary Wyatt's presentation related to It Pays to Care. So what can we do about it? And so this presentation addresses one of the approaches that we've come up with to try and address that skill and knowledge deficiency. So the aim is to find a workforce or a group of people within our workforces to lend their time to raising skills and knowledge. And so we've created and put this proposal to PIEF to create a university-based micro-credential short course as a pilot to explore the interest amongst those health professionals towards upskilling. to dive down a bit into the problem, what's the evidence? And I've been asked that, well, explain it. What is your evidence? But in fact, it's well delineated and described by Mary Wyatt in her documents that back up It Pays to Care. It's also been explored with that collaborative partnership between Comcare and RACGP and every day-to-day claims experience. And they identify the importance of being proactive with your understanding of the psychosocial complexity, but also to promote evidence-based care, to get away from the amount of low-value care that our schemes tend to attract. The target are the primary care practitioners because they play that vital role, and they are irreplaceable in our compensable schemes. Now, the primary care is an access, we know, is also an issue. It's challenged by availability, supply of GPs and that access, and also their willingness to accept the compensable patient. And we're seeing increasing numbers of GPs who are turning away compensable patients. So we believe that by improving that knowledge and skill amongst this cohort, or finding those who are interested to undertake some further training, could improve the outcomes. But that education needs to be targeted, structured, efficient, and of course incentivised. So what exists in our country and beyond? We know that the schemes attempt to interact particularly with GPs and physios with small bespoke webinars to convey the information, particularly around updating them with changes. But the university-based courses we have are more addressing claims managers, not looking beyond our schemes to the primary care practitioners. There's some work being done in that direction in the States, and in Europe, in some European countries, there in fact is a whole specialty of insurance medicine. So we needed to research what was the likelihood that primary care practitioners would turn up to a course if we put it on. And the innovation team at WorkSafe undertook an extensive interview approach to this research. And they came up with 3 broad personas to try and capture the feelings and the mood for this sort of training. And I'll just go through them very briefly. There's the young practitioner who's been in practice for 8 to 10 years, commonly described here as a physiotherapist, and they've been practicing for some time, but they're actually looking to diversify. Can they explore other parts of physiotherapy practice or beyond, or other forms, whatever practitioner they are, beyond what they're doing now? Then there's the pragmatist, and that's described as the person who's recently, either a GP or a psychologist, recently received their fellowship, still in that I'm learning and I'm prepared to put time into education. I want to know more to do my job better. And then finally there's the generalist, and you'll probably relate or identify this particular persona quite well, the older GP who is very experienced, very confident in what they're doing, and they feel they're doing a job that's satisfactory, but they'd be happy to, particularly because they've got CPD requirements, to do some smaller packets of education. And so we structured this into this pyramid. And if you look on your right side of the pyramid, from the bottom up to the top, we've listed the different levels of intensity of educational opportunities, from just that opportunistic education, I've got a problem, I'm going to search to find out how to deal with the problem, or some tailored education programs that commonly the colleges might run, to the postgraduate certificate or right up to a master's course. And when we looked at our personas to work out what we should, the way we should structure this, we decided on this core module, a pilot, which would run for about 10 weeks, and that sits in amongst the aspirations of those personas. Not trying to do a big project for a small number, nor just satisfying that opportunistic education, but to be a little bit more substantial. And so I'll pass to Michael to take you through the next steps of how we developed the course.
Thanks, Hugh. Almost had a workplace injury coming up the stairs there, but probably should have gone up the proper way. So let's have a look. Well, first of all, I should explain a micro-credential is a postgraduate certificate, postgraduate course rather. In our instance, it runs for 10 weeks. That includes mostly online pre-recorded content and then an in-person component at the end. So the process we went through started with some expert engagement, really driven by Hugh, where we ran 3 workshops with 18 experts through June last year. We then went through a process of certification with the university so that we could allow for 6 credit points, so it could contribute to a broader degree, such as a graduate certificate or master's. And we also received 78 hours of CPD approval from the College of GPs, which was great. That's pretty much their entire year's worth of CPD in one shot. Went through a process of content development, which was with really pre-recorded lectures with a number of very high-profile experts in the sector, both in clinical and policy. And we also built some written content that talked to an array of the topics, which I'll mention in a moment. We also built a number of assessment tasks. We made sure to put group presentations in there because we know how much people like public speaking and working in a group. But that was good fun. So let's have a quick look at the content. So it was really split across 7 topics and 2 kind of tranches. First was the art of managing people in workers' incompensable health and medicine, and that included an overview of system design, how Australian compensation schemes are navigated, and some clinical concepts and frameworks. So for example, Hugh and Paul Coburn talked to the clinical framework for delivery of healthcare in workers' compensation. And then the other 4 topics were major clinical domains of importance in personal injury schemes. So this is common conditions such as musculoskeletal disorders and pain, science and treatment of common conditions as well, mental health and neurotrauma and occupational diseases. And as you can see there was heaps of content. We had 25 lectures from 22 expert presenters, 13 hours of content in total. So it was a lot of lectures to watch. I can see a couple of students in the room, so I'm sure they enjoyed watching all 13 hours. So we ran the course earlier this year, 18 participants to start with a 2-day intensive, like I mentioned, the in-person component. It's included GPs, and I should mention the intensive included GPs as well, policy specialists. We even had a justice from the Industrial Court of South Australia who gave us a very interesting perspective on injury management. And so who participated? So like I said, we had 18 participants, just over half were general practitioners, physiotherapists, osteopath, and an EP as well in there, there should be, or 2 EPs rather. 2/3 of participants were females, and we found that most of the students already had quite a bit of experience in both healthcare and in treating compensable patients. As you can see there, almost 17 years on average treating compensable patients. So relatively experienced clinicians that participated in the course. And just over half were in relatively small clinics of less than 10 clinicians. We measured a number of things in our pre-post course survey. Just to note here, this is knowledge, attitudes and practices. The main thing that you can see that changed in terms of knowledge was the new knowledge that participants had in terms of that being involved in litigation or legal proceedings could be detrimental to claim outcomes and recovery. So that was a new bit of information they took away. In terms of attitudes, they took away that, more post-course rather, agreed that goal setting was important. So again, that's positive to see. And in practices, more agreed, or rather strongly agreed, that they would use validated tools to assess outcomes and goals, which was good. In terms of practice intentions, it was good to see that after completing the course, I have made system changes to improve the efficiency. Was 90% strongly agree or agreed there following the course. Not many people agreed that they would intend to move to a medical or health service that's specialised in compensable medicine, which was a little interesting. But that was, yeah, it was quite interesting. And 50-ish% agree that they are spending more time with their compensable patients. Satisfaction with the course was high, which we were very pleased to see. People enjoyed it and they thought it was good value for money. Particularly the content of the course was considered very high quality. So 91% of participants strongly agreed that the course was high quality, and a sizable percentage would recommend to a colleague. There were a number of opportunities for improvement though that we highlighted. So students fed back that content could be more jurisdiction specific, and we tried to include a range of jurisdictions, but when you think of CTP, workers' comp, and the real spread across Australian territories, states and territories rather, that gets quite complicated. Tools and content could be kept after the course, so we had one student reporting that they used a video explaining pain from the course to then show to a patient of theirs, which they said they found helpful, and they would like to keep that content afterwards. The content was very academic and could include more practical examples and activities, which is not surprising given we're academics, so we could include some more practical stuff. A more manageable workload, so we had quite a lot of assessments to ensure students got the 6 credit points and 78 CPD hours with RACGP, but we could make that a bit more straightforward. And hearing from other stakeholders in the compensable setting would be beneficial. So they did speak to an injured worker at one point as well, but we could include other stakeholders too. Next steps for us. So, like I said, student feedback was very positive, and as was expert feedback from the experts, policy and clinical experts that we spoke to. There were challenges in testing the knowledge, attitudes and practice, so we didn't have a very large sample size, so there were no statistical significance tests there, but you'll have to see the percentages and take that. But there's strong demand for the next iteration of the course, which, here's my shameless plug, is due to commence next year in March. There's the link. Places are limited for that iteration. I'll leave it there and then over to Joya.
Thanks, Michael. Thanks, Hugh. Last call for Q&A before we get into our last speakers for this session. So I'd like to welcome to the stage Thea Hobbins from Allianz and Dr. Angie Montgomery from InCheck.
We'll check that this is working. Perfect. So Dr. Angie and I are here today to talk about Mindful Edge and using data to drive prevention intervention in psychosocial risk. So at Allianz, we recognise that the landscape of workplace injuries, is changing and continues to change. And I think we've all seen that psychological injuries are the fastest growing segment of claims, and the impact is real. So it's real impact to individuals, to workplaces and to schemes alike. So to give you some perspective, I'll share with you some claims data that has been gathered from financial year 21 through to 2025. So there's been a 28.4% increase in the proportion of psychological injury being managed across our workers' compensation teams. 29.5% increase in the average cost of psychological injury, and a 10% increase in the average time to return to work. So that now stands at some 81 days for psychological injuries to return to work. also increases across the injury mechanisms that we typically see. So that being workplace violence, harassment and bullying, exposure to a traumatic event, and definitely mental stress and workplace pressure as well. So there's been a lot of work that's been going in over the years to improve the awareness across, organisations, and regulation has come into play for organisations as well to try and address this challenge in mental injury. But organisations are really still struggling to identify, measure, and then address the psychosocial risks that lead to workplace mental injury. So, the traditional approaches of being reactive, siloed intervention, kind of outline that there's a really critical gap in prevention and then linking that to early intervention and the creation of truly safe workplaces. So at Allianz, we recognise that bridging that gap required more than just the compliance element that's driving change, and demanded a proactive, really evidence-based solution that could empower our clients to understand and address workplace injury and assess the impact of the intervention that were actually. So Mindful Edge leverages InCheck's cutting-edge psychosocial hazard management technology, and with the expertise from Allianz, and insights, and it's a digital tool that's designed to bridge that gap between prevention and regulation. So bringing the compliance element into the equation, but then taking that a step further to the injury prevention and really driving meaningful change in that workplace. So it supports our clients in meeting their obligations, which is critical in a changing risk regulation environment, and empowers them to create that safer workplace that we're all trying to achieve, and actually understand the impact of the intervention and what it achieves. So I will hand over to Dr. Angie to outline the platform, its capabilities, and big data and modelling and what the opportunities look like.
Thank you. Thanks, Thea. So I come to this space from a bit of a different background. I'm a health psychologist and I've worked in workplace mental health my whole career, but originally starting as a pain therapist back in the day, I can definitely confirm the experiences of some of the patients that you would have seen in that model that you presented earlier, being very complicated. I worked as a consultant for a number of years as well, before moving into building my own software around proactively managing psychosocial hazards. But one of the many challenges around the workplace mental health space is that we actually don't understand why people are sustaining these mental injuries, especially at the rate that they are. And so we know that we have programs and we know that we have interventions, but we don't know what's effective and we also don't know what to do and when. But the way that we actually find that out is to identify what is causing the issue in the first place. All of the data that we're collecting to date has been lag indicators, so they're historical, they're after the fact. And so we're always looking in the rearview mirror. In order to prevent something from happening in the first place, we need to understand what the risks are. We need to understand what leads to the harm. So now, as Thea mentioned, on the back of the safety regulations that have now changed, we have the opportunity to actually identify those risks in the form of psychosocial hazards. So I started InCheck, which is my software company, about 5 years ago. It was on the back of the psychosocial hazard regulation being drafted, firstly in New South Wales. Essentially, it was built because I was working in the space as a consultant, but found that a lot of the approaches we were taking were very manual. And a lot of the information that organisations need to proactively identify risk is needed urgently and needed quickly and needed cheaply as well. We don't want to be spending tens of thousands of dollars just doing a run-of-the-mill focus group when we could be doing something much more efficient and broad scale. So that's where InCheck was born, built this workforce survey software platform mapped the entire architecture to the code of practice to ensure that every employer had a tool to collect those lead indicators that they would need to assess those risks and see those warning signs before they resulted in harm. I've worked with Allianz for a number of years now, being very innovative in this space, and we co-designed Mindful Edge to overlay the additional nuance of that workers' compensation data so that we can see the lead and lag indicators and the full story that workers and organisations experience. So now that we have Mindful Edge up and running, we are Allianz client workforces are able to identify those hotspots and proactively manage those before they result in injury. Now, creating this scalable tool was just the first of many goals for us. We actually have much bigger plans. We're focused on building big data, and big data is when you pull all of those organisations' results together, looking at hundreds of thousands of data points to create new knowledge, including being able to identify early warning signs across industries, across geographic regions, and making accurate predictions around underwriting as well as what works in terms of mitigation. So we've been using predictive modelling in a lot of different fields for a number of years, and this is how behavioural psychology always conducts research. But it's also been used in insurance for a number of years as well. So since the 1990s, computer-based data modelling started moving into pattern recognition, eventually coming to build models that learned from their own results. So these data prediction models were when AI came. This was AI before our LLM models that you see now with ChatGPT. We originally had machine learning. But it all boils down to this. Computers use large, complex data patterns to identify and predict risk and predict outcomes. It's quite literally AI machine learning, where the computer learns through pattern recognition and then feeds its own data source. We can predict things like future claims, likelihood for specific industries, regions, age groups, and also genders. We can look at different industries like healthcare and construction, as I've got a bit of a mock-up here of some of the big data demonstrations that we can actually produce. Now, the data that's been used to produce these interfaces is actually from SafeWorks' report on data from 5 years. But what I've actually done here is made some inferences about how this would produce predictions for the future. I don't have the whole data set, so you can't actually take this away and use it because it wouldn't be sound from a reliability perspective, but this is what we're working towards with Allianz, to actually produce this with real data. We can also predict the length of a claim and understand how this changes depending on the industry and other factors like geographic region and age. But I think one of the most important things is we can start to look at the effectiveness of the interventions. So imagine that you knew which intervention was the most effective at preventing workplace aggression in a regional school. Or perhaps what was the best for a metropolitan construction site where there were a high number of bullying claims. What about a hospital in a regional city where workers were leaving in droves due to burnout and experiencing conflict with their colleagues? So all of this is possible with big data. But I will leave you with one takeaway. While we're living in an age of data, not all data is created equal. So if you want high quality information and insights, you need high quality data. AI is amazing, but it can't turn water into wine. So if you want to know where to start with getting good data. Anthea's going to finish off with a couple of additional takeaways.
Yeah, absolutely. Data is that key to unlocking value. So, if we think about the value right now with clients, we can actually support and give them feedback on, interventions, the success of those, so that they can actually drive change in the right area and really drive actionable insights, which is fantastic. So they can meet their compliance, but on top of that, actually continually improve their risk culture within their organisation. But exciting about the future and where we can kind of take this, if we look ahead, then it can transform the way that we look at underwriting and risk, and actually not just take backward-looking view on previous claims history, looking at predictive view on risk culture and interventions that are going to be rolled out across an employer. So it's quite exciting when you can think about the transformation that can be achieved in that space. So yeah, really excited about using Mindful Edge to really move from what in the past has been reactive responses around risk prevention, but we've got the power of insights now to drive that forward, not just at a client level, an industry level and a community level, so we can start to really drive interventions that are going to make more meaningful impact to a larger group of people, because let's face it, the data says that we actually need to, and do it now. Thank you.
Thank you both. I'd just like to invite all speakers onto the stage, if we can, please, for the last bit of the Q&A. So come on up. Yep. So we do have a few questions. Brana, there were some comments in there about how impressive the modelling was, which I would agree. Very good. Michael, question for you. Does your content highlight identification of psychosocial factors and early intervention?
Yes, I think I would say that's in, I might refer to my colleagues, but it'll be like week 5 of the course, I think. But definitely, yes, psychosocial hazards and content is in there.
Very good. And was there any consideration to include topics in the accredited training course relating to return to work planning or the health benefits of good work?
I'll hand to you in a second. The health benefits of good work are in the course. Return to work planning is also discussed as well. Paul Coburn has a section on that. But Hugh, did you want to?
No, that's it.
Yeah, cool. Both are in there.
Very good. For Thea and Dr. Angie, with Mindful Edge, what is the timeline application for underwriting?
Yeah, it's very early thinking at this point in time. So we're in the sort of pilot phase where we have approximately 30 organisations across a breadth of industries, workplace sizes and locations who are starting to use that. So by the end of Q1 next year, we predict that there'll be about 102,000 unique data points. So it's going to take that period of time to build that up. But Angie, you can probably talk more to the data side of things.
So in terms of actually producing the reliability that we need in doing those models, I would suggest that we would need at least 3 years of repeated data points to do accurate predictions to a point where we'd be confident around the underwriting component. And then depending on the complexity and then level of drilling down that you do with those data sets, you can actually get some broad brush strokes on that a little bit earlier, but the more you drill down and use all of those different moderating variables or characteristics, if you like, the more data points you need to make sure the power is there for an accurate prediction.
Very good. And what response rates are you getting on the mental health survey?
So it varies quite significantly. We've had a variety ranging from 30% to 70%. And what it seems to boil down to is the level of comms that go into the survey promotion campaign prior to the deployment, and the messaging that organisations put out regarding the purpose and language around the survey's purpose. So the more proactive an organisation is and the more touch points that they have with their workforce, the higher response rate that they get. A last-minute email from the CEO the day before deployment generally doesn't produce good results.
Fair enough. Back to Michael and Hugh, a bit of a long one here. So are there any plans to take this training course pilot to the state regulators to encourage the implementation of mandatory requirements for treating practitioners working in workers' compensation to undergo accreditation through a training course like this.
Wouldn't that be wonderful? Certainly the intention is that this is supported by the schemes, and it's to the scheme's advantage to have a really skilled and knowledgeable workforce. The question before was about the psychosocial hazards, and that's just a core, an essential part of this understanding and what the course is trying to do. But probably asking every practitioner who wants to work in this area to spend 40 hours over 10 weeks to do this rather intense course may not appeal to everybody. It'll appeal to some. So we need to explore how we can have a variety of models that some would appeal to people who wanted to do something in smaller bite-sized bits and accumulate their knowledge over a longer period of time that doesn't inconvenience them quite as much as an intense course over 10 weeks. Mind you, all these practitioners who did the course fitted it around their normal week, other than the day that they gave on a Friday for the intensive, which then went into a Saturday as well.
Very good. And back to you two again. GP education is a great initiative. We have documents available for injured parties that we send them when a claim is lodged. Would GPs appreciate something similar, something that outlines milestones and what information we will request from them and when?
I think that's an excellent idea. One of the things we'd explore as part of a way to engage this more specialised and particularly interested subset of our primary health practitioner workforce is what sort of communications they want and what do the schemes expect in return. Because one of the most annoying parts of practice is the request for reports that don't seem to be entirely informed or relevant to what that patient is seeing. Is there some way that this communication can be a two-way process to the benefit of the patient in front of the practitioner?
And you two again, Michael and Hugh. I was lucky enough to have a Workers' Compensation WA scholarship. I know they're up for grabs again. One understated point was the ability to liaise with people across all schemes from the group assignments. I would encourage people to give it a go. What benefits come from multi-scheme engagement?
Many benefits. Yeah, well, we absolutely, we deliberately mixed up all the group assignments by people with different jurisdictions and who operated in different schemes and so forth. But the feedback we had was that it was a great opportunity to learn about all the other features of other schemes. I can't remember the last part of that question, but perhaps you.
I was going to say, what really surprised us that the students wanted to know more about how the schemes work, but how the other state schemes worked. Now, why was it? It was a surprise to me because they wouldn't be applying that in their work, but that just to demonstrate the real interest that they have in this whole space and how other schemes might do aspects better and differently to the way their state does it. Just out of that desire for more knowledge and better understanding. And that demonstrated to me that these people were really interested to embrace this course. One of the, I think it's worth pointing out that to get this core, this pilot up and going, to really satisfy PIEF that this does have merit, the people who came to the course were quite interested already and knowledgeable, as you saw. Did we change their practice? Not in that way the questionnaire showed, but their satisfaction in they really valued the knowledge they got. And that will I think, be demonstrated in the longer term. But in the future, we want to be able to take practitioners who are exploring this in its early stage and get the knowledge, and that will make a huge difference to those graphs that you saw that Michael put up in the initial phase.
Thank you. Brana, this one's for you. Will your model be able to simulate the impact of a potential policy change in advance or only retrospectively?
Yep, so we can do both. So when looking at things that, or events that have already occurred, that's one of the ways that, I think these mics just hate me. But that's one of the ways in which we can look at testing the models. But in terms of testing potential future policy changes, that's one of the foundational concepts that we're trying to do in the work. So yes, we can definitely test future changes.
Very good. All right, they are our questions for today. I'd like to thank all the speakers, if I can get everyone to put their hands together. Invite everyone to go and enjoy the rest of the conference. The final part of day 2 is upon us, and well done for everyone showing resilience with all the tech today. It's nothing like a bit of resilience at a conference when it comes to technology. Thank you. Have a good day. Thank you. Thanks very much. Appreciate it. Nice to meet you too.
easy. Cool. Yep.
Good afternoon, everyone. Welcome back after lunch. Did you have a good break? Yeah? Have you all been around PIEF Village, and have you looked at all of the fabulous different bits of swag and merch? You got some? Show me what you've got. What's your favorite? Cups, glass wipes. What else? What else makes the favorites list? What's that? Oh, aromatherapy roll-on. Okay, where is that? Okay. So if you haven't, it's a reminder, those exhibitors as well, you know, they put in long hours, they do their very best for us. So if you haven't visited them yet, please do so. And yeah, my favorite, can I just say, was actually a protein shaker. I don't know if any of you have seen that one, but yeah. Oh. I don't know, I'm getting into that point where all of my WhatsApp groups, because we're all women who are kind of nearing 40 or just sort of have gone beyond 40, protein is definitely the thing that everyone's talking about in my women's WhatsApp group. So just putting that out there. So big highlight for me. Anyway, we're now here for what is a bit of a mashup, I guess, of we're going to have a presentation from Dr. Mary Wyatt. We're going to have a panel, and we'll do a sort of mini workshop. So very excited, and I'd now like to, we've got two hosts. We've got Rachel Ford, if you could give everyone a wave. I think everybody knows you. We also have Dr. Mary Wyatt, and I think you've also said everybody knows who you are. But a very warm welcome, and I'd like to invite you up onto the stage.
Thank you so much. Appreciate it. So thanks everyone for coming along today. Public sector, don't need to tell you about the challenges of the public sector as I'm listening to schemes, 15 to 20%, I think, are mental health claims. That's what I'm hearing around the country. So big issue. How do we deal with the public sector? Today is really aiming to talk about how we hook them in, how we engage the public sector. We know in the private sector, you can go and talk to CFOs and CEOs and talk money. You can talk very clearly about money, and that's a very clear engagement piece for them, and that's their job, so it's important. But how do you then engage the public sector where the drivers may be different? So that's what we're aiming to do today, is kind of to look at that. I'm doing a fairly short presentation setting the scene, and then we've got a panel session with pre-prepared questions and then questions from the audience, and hopefully a little bit of time at the end for table discussion. We've got on our panel, and I'll introduce them now fairly briefly. Jason Ladelli doesn't really need much introduction, but a background in health economics, done a lot across schemes, particularly the TAC, and now having all the joys of Return to Work Victoria. Ash Evans is an actuary, a lot of experience in long-term predictions, and works with a number of schemes. We've got Emma Hosking, who's from Gallagher Bassett, doing a lot of public sector work, particularly they're going to talk about NT. We've got Eva Lai, and Eva's a star, one of our, what we call our government champion stars. So Gold Coast Hospital we've done a series of webinars as Gold Coast Hospital, have done a lot of great stuff and created change, and Emma's been at the lead of that. She's the Work Health and Safety Manager for Gold Coast Health and overseeing the injury management practices there, and got a lot of depth of experience, and we're doing really good things. And then the last person we've got on the panel is Christine, and I can't say your surname. Thank you. Christine's from the Office of the Commissioner for Public Sector Employment in South Australia, who interestingly are the body that manages the government sector in terms of injury management. I haven't heard of it being housed in that sort of department elsewhere. And listening, I think there's probably the most mature system in terms of thinking and implementation about key things. So it's great to have Christine involved. So just talking a little bit briefly about the public sector, what are the options? What can we do to influence the public sector? Well, of course, legislation, but that's a very crude measure. Can we be using performance indicators? Can we, and that's kind of the next couple are like expanding on that. So can we be looking at the direct and indirect costs and talking about that? Can we be talking about other levers that might make a difference, like bums on seats, because a lot of the public sector are short-staffed. So is that like an interesting thing that they might want to be engaged with? And could we be having league tables? So this is my kind of dream, league tables of return to work, but also culture. And those metrics are then shared more broadly. Education engagement, that's what we're up to today. How do we educate them, engage them? Storytelling, we don't talk a lot PIEF sessions about storytelling, but we do know it really is important and evidence-based. And can we all be aligned? Like if the claims agent or the insurer and the regulator and others are aligned, can that help? The green button. So I'll skip over that and just talk a little bit about all culture, because while we're dealing with mental health claims, the patch-up job is so difficult, and we don't really have the tools at the moment to be effective in managing such cases. We do our best and we're trying hard, but there's a lot of issues. And so how many sessions have there been at PIEF about prevention? It's not necessarily what we do, we're post-injury management, but hey, there's such an opportunity here. How can we not be tackling prevention in the public sector? So my slides I've mixed up. So this is data, many of you will have seen this slide. I'll seen this chart before. So over on the right is the psychosocial safety climate. It's a tool to measure the climate, the culture. It also takes into account leadership. It's like a screening tool. You're not going to find out where the psychosocial hazards here and here and here, but it can be used as a screening tool, can be used for seniors in the government sector. It'd be great to see that being used. But look at those results. High psychosocial safety climate, 8 days on average return to work. Shitty workplace, low psychosocial safety climate, average 52 days to return to work. So it's just like one piece of data saying the org culture is huge, so shouldn't we be thinking about it more? Other correlates with I'm not doing well here. Other correlates with the psychosocial safety climate are all of these things: better psychosocial health in the workplace, less bullying, less distress, less staff turnover, better productivity, and on it goes. So it's just so much, but how do we convey that to the senior leaders when they're battling their cultures and their own systems? So that kind of transfer of information is really important. And just a few practical examples here. So this is data. Anyway, people might remember the wonderful, wonderful Peter Cotton, Dr. Peter Cotton, clinical and organisational psychologist. This was a little study he did, surveys in a school, terrible climate, all the measures, low morale, blah, 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 blah. They had a leadership training program only for the principal and the deputy principals, nothing else to do with return to work, and look at the claims costs coming down with this return to work, with this leadership intervention. It's just one little study highlighting in a school how much difference that org culture makes. And we know across other organisations, so poor leadership, high workload emergency services, we're seeing all sorts of problems. And in fact, when you really delve into the data, the org culture is more of an influence than, say, the individual case of PTSD and the trauma. And we've known this for decades. The supports are really important, particularly if you've got mental health stuff going on and you need to be dealing with a lot. So value in looking at that. This is part of a series we've done with It Pays to Care. We did a government symposium attached to the Comcare conference last year, supported by Comcare. We then have had a series of webinars from people who've done really well, Fire Rescue New South Wales, Eva and Gold Coast Health and others. They're available on the It Pays to Care website. And so these are the things that came out of the last session. Competing priorities, we hear a lot about that. Limited visibility of outcomes, cultural inertia, lack of research. I've put that in red because that's my favourite. We really don't have that deep dive to understand what's going on. How can we manage it if we don't know? Transient nature of the workforce, we hear that again and again. People in acting positions, bureaucratic drag, fragmented over ownership and fear of blame. So there's a lot of things that can be done to influence senior leaders, and that's the aim of today, is really to talk through that more. So if I could invite the panel up onto the stage, and we'll start with thank you very much, just a little. Is that the way? I'll leave it. Thanks everyone for joining us today, coming from far and wide with your expertise and skills. Dare I move this? Just a bit rude with not being able to see you there. Jason, I might start with you. What do you think? You've been looking at this. You've got that strategic brain. What do you think are the best opportunities to get the public sector involved and improve return to work? Thanks.
Thanks, Mary. So there's probably a number of things that we're looking at in Victoria, but I guess one of the things is about how do we how do we get greater input from department heads, department secretaries, and then how do we work both from the ground up and from the top down. So in Victoria, what we're doing with WorkSafe Victoria is making sure that we can communicate quite clearly and quite simply what it is, the factors that we think lead to durable outcomes and return to work. We're also looking at how to put more formal letters, I guess, or formal measurements into departmental secretaries, the letters they get every year from the Minister, that actually has greater transparency with what the target, what the effort needs to be, and where those variances are. And so that's something that we've talked quite openly about, and there's buy-in for that. And another area, I guess, is which we've talked about at the symposium, was how do we look to try and devolve the premium more down into the departments, as opposed to just held at a departmental level, where there's no exposure, no real buy-in to it, because it's all held back centrally. So we've made a bit of progress over that period of time. We've definitely got our minister on board, who's quite supportive of what this looks like, and so that's probably where we see the greatest fruit for us at the moment, where we've got an engaged audience. Our scheme is starting to return to a degree of stability, and so everybody remembers the recent pain of how hard it was and how desperate it became, and so we're using that as a bit of momentum to leverage that buy-in as well.
Thank you. Thanks, Jason. Eva, can I change your questions entirely? Sorry about this. But you've you've been focusing on that sort of cost approach and making sure that there's transparency about that cost approach. Could I ask you to sort of talk to Jason's point about that and how you've tackled that?
Yeah, absolutely. I think from my perspective, whilst we at Gold Coast Health do pay our own premiums, it's not paid by the Department of Health, we're actually very much informing all of our board and our executives around what the actual costs are, and not just the output for the premiums, but what those other hidden costs are. We're at a point now where we feel like we actually need to drill that down, much like you were saying, rather than keep it at that departmental level. At a smaller scale, we're now looking at, we now need to scale it down to a divisional level. Not because we don't have the buy-in, we do have the buy-in, but we don't have enough. They need to understand it, and the only way that I have found that has worked for them to understand is it has to come out of their budget, and when budget's affected, that's when you can make even greater change. So I do think that, you know, drilling it down, I think is a very, very good sound approach, and I genuinely think that you know, you probably will get far better outcomes, and not just for the premium side of things, but ultimately that's, I guess, a byproduct of getting really good outcomes for our workers. So I would be wholeheartedly, I believe that that's probably the one way that we at Gold Coast Health, that'll be our next way to improve on what we've achieved.
It also helps with accountability, doesn't it? It's not just, it's black and white. Emma, if I could go to you, changing the sort of topic a bit, you've got the added problems in the territory of not only emergency services challenges, but quite remote. I mean, a lot of places have remote, but it's particularly an issue in the territory. Can you talk about how some of the ways you're dealing with that?
That's better. Thanks, Mary. Yeah, definitely. NT, remote regional challenge. If you speak to anyone really working in that space, the feedback I consistently get from managers, workers alike, is that it's one of the most rewarding opportunities for them to work remote and with the communities out in the remote regional areas, but also one of the most challenging at the same time. And it boils down to those sort of wellbeing factors that you talk about. You know, the isolation, the fatigue, the burnout, the work-life balance, etc., which is just such a challenge for them all. I'll probably focus a bit on Northern Territory Police. We're working really closely with them at the moment and really well engaged with them at the moment. There's a lot of focus. There's been inquests, there's been reviews, there's been all sorts of attention up there around the challenging conditions of their workforce face in the regional communities. It's been underway for quite a few years, so they have developed a significant wellbeing strategy, and police are trying to roll out a lot of initiatives in relation to that. We're involved in one of those, which is the My Wellbeing program, and that was designed specifically with remote regional in mind. So it's essentially a early education sort of prevention type program at that front end of the mental health continuum. So it's more about empowering and educating when someone might be more in that thriving space, maybe just some early indicators of risk rather than sort of further along the continuum. And it's really an online platform, so anyone can access it 24/7, at home, at work, if it's more appropriate on their mobile, whatever. And it delivers a few different things. It's resources, obviously. We tailor them. We tailor them for the police profile, for their language, their style. They'll only look at it if it's got pictures of coppers on it, etc. And for fires and emergency services, similar. We have separate landing pages for all of them. We need to. But also based on the risk profile, we use the data. So through the portal, we can individuals can go in and undertake screens. So they can do a physical health screen, a mental health screen, or a financial health screen. And from that, they get a risk scoring and a profile, and if they can voluntarily opt into coaching, independent coaching, if they want to, which is really important for police with the stigma, the nature of policing is they're very suspicious, and the level of trust is low. So that's really important. So from that, we get a lot of data and insights, so we can tailor what we then prepare in terms of health promotion campaigns, in terms of the health clinics, the forums we run, the resources we put on the portal, etc. We go out into the remote regional communities with the agency. We co-locate with the agency. Our staff sit in there amongst them, so they understand it, and they travel out and they try and do that face-to-face and level of engagement that's definitely necessary. The other thing we're doing is just upgrading the portal at the moment so that we can have regional communities and a regional community space on there. So we can obviously promote what we're offering in terms of it might be a forum or a health clinic out in a particular remote regional area, but they can also put their own it could be events, it could be services, it could be the local run club, for example. They can be putting that up there and using that as well. And then on top of that, what we're finding is that based on the data, the insight, the feedback from police, we're extending the range of services. It was initially just physical mental health, now it's financial health, because that's a big focus for police. And we've included cancer care in there as well now, so they can access for individuals suffering from cancer or experiencing cancer, caring, or even line managers who are supporting workers as well in that space.
So you have got a massive program focusing on really prevention. A lot of energy going into that. Thanks. Ash, if I could come to you, or if the microphone could come to you too, the 60 million or the $60 billion question, what are incentives for the public sector? What do you think an effective suite of...
Yeah, well, an incentive is, look, it's a very tough question. Where there's a deficit, the system is made up of rules and incentives. The rules have developed a long way over the last decade or so, I think. They sort of provide a minimum standard, but you really need incentives for all your parties to want to maximise the outcomes. It waxes and wanes over time in terms of how high up the list financial sustainability is, but it's probably fair to say we're in a waxing stage at the moment in a lot of schemes in Australia. So things like, return to work, it's always been topical, but return to work takes a sharper edge at the moment in terms of an outcome. And the incentives in the system are really clear or quite clear for a claimant via the scheme design in that question. And I think the designs differ across schemes, but it's legislation to change them. There's also very clear incentives for people acting together, and it goes to your earlier point on the slide, Mary, around alignment. of objectives, and there are incentives in place between insurers, whether publicly underwritten insurers, and claims managers, particularly if they're external. These things get built out. But what what I don't see a lot of, and it was super interesting, Eva's taken it because there it does exist. But in the conversations, in my perspective, there's not a lot of talk about what the incentive is for an employer to return somebody to work. There's rules, there's what they have to do, but very rarely do you hear the question, which sounds a little heartless, but you rarely hear the question of what's the return on investment for an employer taking someone injured back to work. It seems inevitable that they should, but it is a decision, particularly in workers' compensation schemes. Someone who's previously had a claim, it didn't necessarily returning to the same work, but someone who's previously had a claim is more likely to make another claim, for instance, particularly in the space around mental health and psychological injury. Certainly there's a heightened proposition of re-injury. So I think where it incentives we need to do more work is aligning the incentives of the scheme or the insurer and the employer a bit more closely. And financial incentives work.
Do they work in the public sector?
I think so. I mean, as Eva said, the budget of the public sector, I mean, public sector and private sector are sort of same, different. Like the public sector, large agencies will often act a bit like a business. They do care about their budget. They might not react the same way to some incentives, but at the same time, there's also a greater opportunity in the public sector because they are employers within a larger employer. So you should expect there should be able to be greater employee mobility, for instance, and things like that, and opportunities around those. And so when we talk about incentives for the employer, it might not necessarily be taking their own employee back to work, but an injured employee back into their workforce. How are they incentivised to do that? Now, Jason mentioned the premium. The premium is pretty much the only incentive in most schemes for an employer. It goes up if experience is bad, it goes down when experience is poor, but it moves for all sorts of other reasons. And it's very disenfranchising if someone's taking an action and the RBA reduces interest rates so their premium increases anyway. This is not, when you're designing an incentive, and I'd be interested to hear the thoughts of the rest of the panel, it's really important that it's got a really tight feedback loop. You've got a sit, reward, drop, reward, roll over, reward. There needs to be a feedback loop that's really tight. A premium is not tight. It is long and it moves for all sorts of reasons and it's complex and all these things I love about it because you need to hire actuaries to calculate them, but it makes it an ineffective incentive a lot of the time.
Thank you. Very useful. Christine, if I could come to you, Ash spoke about employee mobility in the public sector, which has been a huge issue across the country.
Yeah.
And so we were really quite excited to hear about South Australia and the legislative change so that the government is an employer and so there's a responsibility to even move people across departments.
Yeah.
So can you talk a little bit about what you're doing and how workers can be supported to transition to alternative roles when that's needed?
Yeah. In terms of supporting injured workers in the South Australian government, there was legislation passed last year that sees the South Australian government as one employer for the purposes of return to work, so a single employer. And I think it opens an opportunity for injured workers, particularly workers with psychological injuries, and getting them back to work earlier, and maybe not necessarily in their own agency, in their own department, but it opens up a door of opportunity to mobilise them and get them back to work earlier, which we all know is so good. And
for return to work outcomes in general.
That's massive. It's a
Yeah.
massive change. And do you know how it came about? Like, was it from the government or?
Yeah,
yeah.
it was from the government. So I think the government has been working for some time to reach that point. And I think there was some case law that came out that sort of went against that. So I think it was, my view is that they thought that it was time to actually do something about it.
It's amazing. Has anyone else heard of that across Australia? A scheme where you've got a responsibility to return people to the government sector, even across departments? Heard of it happening? Haven't heard of it happening? Haven't put your hand up? Thank you. We'll be really interested to hear about that as it goes on. Thank you. Cool. So, Eva, if I can come back to you, you've done amazing stuff at Gold Coast Health. Yeah. What advice would you give people who want to make change?
Probably the first thing I'd say is buckle up. It doesn't happen overnight. It's definitely a marathon. I think, again, without the support and the engagement of the board and the executives, you can tread water all you want, but that's where the real influence happens. And don't give up, I think, would be another piece of advice, and really get them to understand, like genuinely understand, how the experience-based rating works. I'm not sure if that's the same across all schemes in the country, but in Queensland we work on an experience-based rating, and if you have a look at the formula, and Ash, you'd probably, chuckle when you have a look at it, but when most people look at it, it's very complex for them, and it's really about breaking it down and them understanding that what we do today actually carries a 4-year legacy. And once you're able to get that through to them, I think the rest flows on. But yeah, there's not one magic bullet. So yeah, that would probably be my advice.
Can they all come to you for advice?
Yeah, sure, go crazy.
Good. Jason, if I can come back to you, you've talked about how we talk to the seniors, ministers and secretaries. Can you talk a little bit about what other things Return to Work Victoria is doing to try and tackle this vexed problem of the public sector?
Yeah, thanks, Mary. So there are a number of things we're doing. One of them, which is a bit of an oldie but a goodie, is we're re-establishing a public sector team within WorkSafe, and almost going to, I think, to what was said earlier about how part of that is going to help to train departments to understand how the premium works, to understand how valuations are working, to share this data and information, because it can be quite confronting. It brings back high school calculus sort of fears, and when people see that stuff, so you need to demystify it. And so part of what this team's going to do is to help to try and demystify, illuminate the data, but in a way that they can understand it. I think it's also important to what Ash was saying, is that the premium cycle is too slow, and so how else can we try and use a mechanism that's already there and widely used in insurance in another way? And so at WorkSafe, we are fortunate in our scheme to still have the regulator as part of WorkSafe, as well as the insurer.
Safety side.
Yeah, that's right. The health and safety part, who regulates health and safety in the state. What they are looking at, or part of the discussions that are going on with my colleague there, is about how we can better use the prevention, or an incentive that incentivizes lower claims that have been submitted for certain injuries, that can be in the form of a grant that's given to the department, the employer, and that correlates within a 12-month period rather than a 3 or 4 year period of the premium. And so because what we find is that these departments are trying and working hard, but they're not given great windows to work with their boards and that, and so we need to throw them a bone so they can throw their boards a bone, so that everyone thinks, oh, this is worth investing in, and so that's why it's forced us to have a look at how that might play out, but more from our prevention side of the business.
So just following up, on the prevention side, and this is not necessarily a question to you specifically, Jason, but if you've got it, there's culture surveys of most of the public sector that I'm aware of, certainly Queensland, Victoria. Is anyone using those to look at what's going on with workplace culture and correlate it? I think New South Wales might have done a study correlating the culture surveys in the public sector with claims. Anyone aware of that? Are you? Cool. So looking at the health departments, your own culture surveys, because there's state of the public sector surveys, isn't there? Yeah. No one's using them?
No, they go into part of the factors that our health and safety regulator uses just to see what sentiments and shifts there's been, especially on the back of COVID being quite pronounced in Victoria, the effects of that and the tail effects that continue to come out of that. I know there's been a lot of reference to the state of the public service.
And is that being used then for comp? Because it kind of makes sense if we look at the all culture surveys, it's different surveys, but same sort of thing. Are we looking at that to sort of bring that into the mix to report on in comp? Because that's a lead indicator. Yeah.
Yeah, probably not as much as we should, Mary, but we tend to, I think, our actuaries assist us, and we tend to look at it. I guess we look at it through the numbers first, and then we have a look back and say, oh, okay, well, this is probably some of the behaviour change that's presenting in the numbers. So maybe we could look that way rather than the other way, but at some point it does become a factor for us to look at.
Well, yeah, generally we're so focused on, this is not necessarily this topic, but we focus on lag indicators, but there's so much opportunity to focus on lead indicators to go, because if you've got the lead indicators right, the rest follows. But anyway, that's my throw in when I'm supposed to be asking questions. Emma, if I can come back to you, psychosocial risks, you've talked about the well-being stuff, and we know that remote NT is isolated, like lots of places isolated, WA, Queensland, but it feels more isolated in NT because of the small communities out there. What are you doing to try and tackle or address some of those isolation risks or other psychosocial risks?
If I come back to perhaps some of the work we've been doing more closely with NT Police again recently, but they do apply to the broader territory as well, and the government in particular. Sort of three factors I'd probably pick out that I would focus on. In policing in particular, the complexity of the operations, just the nature of, the highly regulated, the level of protocol that's required, etc. The multiple systems and requirements which are essential, but we've just finished a journey mapping exercise for the worker and line manager experience with NT Police, and I think we mapped it sort of from wellbeing pre-claim right through to claim resolution, and I think there are 6 or 7 different avenues for someone to notify a claim or lodge or an incident injury, almost through critical incident systems or this system or that system, and multiple channels. So it's really complex for an officer in charge or a worker trying to map the pathway for care and support when that's sort of all coming in that way. So consistency is probably the key focus at the moment. It really is about trying to provide some consistency around the provision of information, the guidance information. We're working closely with them to collaborate on that at the moment. The second factor I'd probably think that's really come out that I think we understood but didn't quite realise how prevalent it was financial impact and implications. I've touched on it before. For police in particular misinformation or misunderstanding about the financial impact of lodging a claim, the feedback I'm getting is it's preventing individuals from lodging a claim. Just could be only a few dollars, but they're just being short a few dollars in the difference. There are other options out there for police and emergency services in terms of fairly generous sick leave provisions, or the private health arrangements through the not private health or the government health arrangements through the police scheme, etc., is preventing them from lodging claims, and we're not able to get in and act early. secondly, I think coming back to that isolation that you're talking about, Mary, the workforce shortage in particular, there's regular overtime available and very readily available because there's always work out of remote regionals. So you've got often younger workers who are picking that up and earning very high wages, and then their lifestyle adjusts to that. And then the feedback we're getting from the agencies themselves is that the wellbeing impact of that is really, really significant. The burnout, the physical and mental burnout, and the financial stress that that's causing, and we're seeing that through the My Wellbeing program. We've had a very strong utilisation in terms of that financial wellbeing screening, and also the coaching that's being picked up as well. And then the third one that I thought was probably a bit unique, not unique across Australia, but probably more prevalent in the Territory, is that the Northern Territory Public Sector's workforce strategy has a very, probably a heavier reliance on skilled migrants in terms of the workforce and the impact of that in particular. Understanding that, there's greater stigma with culturally and linguistically diverse communities, the understanding and awareness of misunderstanding at times of the Western treatment, etc., and the limited knowledge of the services and supports that are available means that you have low engagement for treatment and support, you have increased severity of injury and illness by the time claims are lodged, and low family care and support for the worker through that sort of care and recovery process. So we're having to sort of focus on that in terms of making sure our staff are educated, are aware to be able to identify that, to be able to have those conversations with the workers and their families as well, and be able to engage to support appropriately.
Thanks, Emma. Appreciate it. Christine, back to you. This is a really interesting one. How do you think we can influence the mindset of frontline workers who need to change a direction? So they're not able to go back to their normal job. The group I see with this is the most difficulty is the paramedics. Because they just love being a paramedic, except for the old ones who want to get out. But how do you kind of shift that mindset of the identity and the whole world needs to change?
Yeah. So I think there is a real opportunity here to influence those younger groups of workers that are coming through to see it more of a broader part of their broad occupational sort of pathway rather than a career for life. So, and I guess that just includes, getting them to think about things as they're going along, as they're getting their training and as they're upskilling, and, to think about, well, I'm doing this now, what can I learn? How can I continue to learn? And even set it as a mindset from the beginning that, it might not be for life. It might be, but it might not be for life. So, I think there's a real opportunity there to actually, influence that. And,
Fantastic. There's, we did a session with a vocational coach once, and she worked with Coles. And so when somebody couldn't get back to a job in a supermarket, it was vocational support, but really getting into the deep. It's not the superficial, or not the, here's the list of jobs, but really deep coaching. And there's the opportunity there, isn't it? Because it's a big shift for people and their mindset. And
because they start off with, and it's advertised in that way as well, that, it's a career and it's their whole identity, and it becomes them, It's
family.
So, so if there could be a shift to sort of, right from the outset, if, people are going into those occupations knowing that perhaps, in 15 years' time I might need to be doing something else. And I think there might be some learnings there from Defence. I think they do, the Defence Force have sort of exit pathways as well. So there might be some learnings there.
Exit pathways, that's a really great way of talking about a big need. Yeah, thank you. Ash, coming back to you, the simple question, how do we get better outcomes in the public sector?
Well, I think I've already showed my hand on incentives with employers being a large part of it. I think where, And I think also to your earlier sort of question, and in hindsight thinking about a little bit, the question of, okay, that works in the private sector. Does that actually work in the public sector? I think it's been shown to work incentives through the public sector. I'm lucky enough that as well as through injury schemes, I get to do quite a bit of work in the public health space, and from the decade from the 2011 National Health Reform Agreements, public hospital cost inflation, and I know I'm very focusing in on financial when I talk about things. It's my nature. I apologise. I'm cold like that.
We want it. That's why you're here. Talk about it.
The medical inflation was extraordinarily low for 10 years. Like we're talking, low single digits, 3-ish, whatever percent, which in medical inflation is remarkable for a decade following the National Health Reform Agreements. In large part to the financial incentives that are put in place that flowed from the Commonwealth to the states, to the LHDs, to the wards. It's certainly not the whole story, but it's a large part of the story, and as with everything government, it became second nature that it worked. People forgot that's why it worked, and now it's being fiddled with, but that's another story. But it does translate. Financial incentives can translate really well when well defined and when the objective's clear. So to define what a good outcome looks like, the scheme needs to know what their objectives are. As I said earlier, financial sustainability is big on the radar of a couple of schemes at the moment. There's potential reforms in New South Wales, big asterisk on potential. There has been recent reforms in Victoria, modernisation in Western Australia, a few years ago now in South Australia. The reforms on the horizon, and largely they're to do with financial sustainability. Return to work is obviously a massive part of that, and it goes to that earlier question on the premium. It's often a really bad tool impotent tool for financial sustainability when it comes to legacy claims. And if I think about the scheme, one of the schemes I have most to do with, which is Comcare, Eva talked about sort of we're making 4 or 5 years decisions. Comcare's making a 50-year decision when it comes to making claims because they don't have exit. So it's making very long-term decisions. And no premium kicked up with that. So the premium by design forecast what next year looks like. So unless there's a systemic reason why someone's got a long-term claim, it actually doesn't get reflected in the premium. So what's the incentive an employer has for that person to return to work? And for the psychological, for a psychological claim, which is very common in public sector, it's the topic of today, what is a good outcome? What is your objective? And the financial one is return to work. Well, how do we define that? Jason talked about durable return to work. I think, again, putting on my public health hat for a moment, the physical world of, physical injury world of linear recovery doesn't necessarily make a lot of sense in the psychological injury space. It might be that durable return to work still has some periods that aren't at work after the initial return to work, and maybe that's a great outcome. And again, if we define these objectives better as a scheme and then start drilling down and say, well, let's define a good outcome for a psychological claim, so someone needing to take a week off is not a failure, and we can then monitor it better, then we can start to understand what produces a better result, then we can design incentives to encourage that result.
Thank you very much. Emma, if I can come back to you on a different question. Just going back to engaging the seniors, you've done a fair bit of work on that in NT. Can you talk about the work you've done on that and then what's been the payoff or where you're at with it?
There we go. Similar to what Jay was talking about before, we've adopted a similar engagement approach with the Northern Territory Government in terms of managing their workers' compensation for employees. This is kicking in and out, I think.
Ash, would you mind?
Thanks. So bottom up, top down, same sort of approach. At the senior level, we've been fortunate to be invited to be part of the Senior Officers Advisory Group, which is chaired by the Commissioner for Public Employment, similar to Christine's division in Northern Territory. So she oversights that group, senior executives work as a whole of government. So it's a really rare opportunity, I guess, in a smaller jurisdiction to be part of that. So we are inputting to their strategic action plan. And have been able to put some of the sorts of things we've talked about today on the table as part of that. So setting KPIs for senior executives, looking at a cross-agency whole of government approach to return to work is on the table as well, though it hasn't kicked off yet, still a lot of work to do. And potentially looking at culture as well. So we're hoping to probably have Mary in to facilitate a workshop with the senior execs to actually talk about how to create the appropriate culture that drives return to work. And we will be supporting one of the agenda items for us too is definitely around that reporting that Eva was talking about as well, supporting them with internal reporting that identifies costs, accountability, all those sorts of things as well, which we see is really critical.
Thank you. So you're reasonably advanced with that.
We've got it in and on the table on agreement. We've just now need to execute. We've got the commitment, which is good.
A small thing.
And the other thing we have been able to it's kind of timely because they're also drafting their injury management framework at the same time through the Commissioner's Office. So we're going to be able to input to that and align what we're doing. So as much as we can, we're just trying to align, bring that evidence-based sort of focus as part of it.
Alignment, good engagement, alignment, yep. Jason, coming back to you at the end, same simple question that I asked Ash. What do you think? What do you think are the greatest opportunities to influence the public sector and improve things?
Well, one of the things in a simple thing that we're sort of exploring, or a bit more than just exploring, is we have one book in Victoria, so our public and private sector are all in the same premium, are all in the same book. And so how can we look to separate that out a bit more so that there's unearthing a bit more transparency, potentially exploring putting that in our annual report. So some clever journalists can read it and maybe
effective engagement, yeah,
might help, because I think it'd be the same in all the schemes. Is that the public sector's, if you split out the public and private premium, the public sector premiums will be higher than the private, and so for some people that's a discovery. So trying to make that sort of information as easy for people to see, to ask questions and be curious about, I think is the other. The other thing is also in Victoria we have the psychological regulations which are going live from the 1st of December this year. So most of the other states have also rolled those out, and there has been, and I think all of the other states have sort of seen an increase in the number of claims that are lodged as a result of those psychological regulations. So it's good that the awareness, I guess, is getting out there, but what it ultimately drives is a transition that's needed for us to have more psychologically safe workplaces, whether they are private or public. And what does the positive duty of care mean for in public sector's eyes, for public sector departments? What does that mean? What does it look like? We now have these regulations which we can actually stitch what that means. And so through our regulator arm as well, coming in to sort of help them first, and then following up with a little bit more motivation and making sure that they're keeping safe workplaces. Because I guess at the end of the day, while we're driving return to work, if we don't have the claim to begin with and we're providing safer workplaces, then we don't need to worry about return to work, or the workplace is actually a great workplace that people want to return to work in. And we're finding that that's part of the challenge as well, is that some of the workplaces still continue to be quite toxic for them to return to.
If I can come back to you, thanks Jason. If I can come back to you, Christine, what have you found in South Australia? What mechanism and incentives have you found useful to engage senior leadership and drive accountability? Because there's two parts, isn't it? Engagement, but there's also accountability in your seniors.
Yeah. So unlike other jurisdictions, the South Australian government doesn't operate a premium-based scheme. So we don't have access to some of those financial levers that maybe other jurisdictions do. But it is a unique challenge for us. But our senior leaders do tend to be engaged with the goals of the health and well-being of the workforce. So we have a dedicated safety, well-being and injury management strategy, and the CE performance in this space is considered as part of their performance review.
Ah, so you've got it in the measures.
We've got it in the measures.
Does anyone else around the country have it in their measures? So you'll have it in your measures, won't you? Is it at the directorate level or lower?
Yeah, at the chief executive level.
Okay, so you talk chief exec as opposed to, So you've got it at the senior level.
Yeah.
Anyone else, anyone know any other schemes where it's a KPI or measure at the senior level? One? Chris, so that's ICWA, is it the public sector? Great, might come back to you on that, thank you. Fantastic.
So they're measured on things like officer engagement in work health and safety forums, continuous improvement in work health and safety, leadership commitment to wellbeing, the percentage of managers that receive training in their responsibilities for returning injured workers to work, and incidence rates of significant injuries, so those injuries that have had more than 1 week of lost time.
It's the ultimate goal, isn't it, to have it in your performance indicators, what you measure, what you're focused on.
And
That's
it gives them the
fantastic.
opportunity to, we have other reporting as well, quarterly reporting, which picks out some of those things as well, but also, the things like timeframes to determinations and that sort of thing, which sometimes, can be detrimental if they a little bit too much. Particularly in psychological injuries. So they can see how we benchmark them against the other agencies, and they can see how they measure up against their counterparts. So I don't know necessarily if you call it a KPI per se, but it is...
It's a measure.
Yeah. So they're given their measures and how they've performed.
And how they compare to their peers. It's one of the few things that influences us doctors. If you tell a doctor their behaviour compared to everyone else, it's one of the few things that influences them. So it makes sense that it is influencing at that level as well. Thank you. You've got a lot of good systems happening there. And so this is the last question, pre-prepared question for the panel, and then open to you guys to ask questions or talk about your system and what you're seeing is working well or what you're seeing that's not working well. And it'd be great to hear from Chris about that pre-move to start with. But I've got one great question to ask Eva to finish off. What are you most proud of?
There's a few things, obviously, that I'm really proud of, like I'm sure everybody in this room, but we were talking about culture earlier, and Gold Coast Health has, aside from the public surveys that Queensland has, we have a Going for Gold survey, which Best Practice Australia runs every 2 years for us. And I think one of the things that I am genuinely most proud of is that my team have reached a culture of soaring, which is in the top 2 percentile of everybody that has been surveyed by BPA, and seeing, growing these people and then seeing them transition and often move, which is sad but great at the same time, and seeing their careers flourish and taking the learnings that they've learnt here to other places and often to other government agencies. So I dare say is probably the thing that I'm very proud of.
Lovely. And it just makes so much sense, doesn't it? I mean, we think of maybe return to work as, this and this and that and this, but we are the people who are setting the standards. How we behave at a scheme level and at a policy level and at whatever level influences how we all behave, doesn't it? Standards are contagious, and so if that's the standards of your team, then that will flow on, and so it just makes perfect sense. And it's a lovely note for me to finish on and hand over to the wonderful Rachel Ford. So for those who don't know Rachel, she's one of our team. Her day job is at Suncorp in policy and reg, and Rach works with us a day a week and has been focused on the public sector. So she's going to run the second section, or this section now, taking questions from the audience. And over to you, Rach. I'll do the mic. You
Sure.
start off and I'll
Did
come
you
down
want
to
to
the
start off, as you said, with me handing over to Chris to touch on that? Just so you all know, sorry, I'm hiding at the back now. You actually, we have questions prepared on the tables when we have a symposium, when we have a workshop. However, the nature of the conference, we didn't know if we were going to end up with 2 of you or 100, and if you're all going to be at the same tables or not, or if you all knew each other, which also changed the questions depending on whether or not you're all insurers or employers or who you are. So we're playing a bit differently. And we will start off, I was going to start off with questions for the panel, but Chris, since you accidentally volunteered yourself through Mary, here you go.
Very quick. It was just a comment on public sector accountability, and we have similar sorts of structures that was described for South Australia. But the only point I'd make is there's got to be consequences. We have pretty good transparency of data, but it's a bit of so what. And one of the perspectives in the public sector is who is the employer at the end of the day, and if the public sector equivalent in the jurisdiction doesn't step up and take it, then it does devolve to individual agencies and their own CEO and other imperatives which drive it, rather than full accountability up. So I've seen some very ordinary performance in both safety and workers' comp in government agencies, and nothing happens.
So in that, I think there is a question for the panel, but I'm not too sure about what we can do to influence that. Eva, I think I'm going to go back to you. Let's just chat about, because you obviously have got in there and you've changed this and you've changed that culture and you've made people accountable, and I know that it is because of the fact that you've put that data there, but that data wasn't always there, and the premiums didn't always affect those people individually. So how did you start that change?
Well, we started internally, obviously, just at our own health service. And I think we've reached a point now, because we have managed to move the dial in a positive direction quite significantly, that we're starting to have influence further up the food chain to the Department of Health. So we've been working with the Department of Health and with sister health services to work out, right, where are you at? These are some things and tools that we've got. These are some recommendations that we make for you. And I think by sharing those resources and sharing that knowledge, not only is it really good for them to, have a starting point, probably a little bit more advanced than what we started at, but it's a positive influence on the industry in general. So in our small way, I guess we are sort of influencing both internally within our own health service, but beyond that to other health services and of course to the Department of Health.
So in this case, it's really been the people on the ground making the change, seeing changes needed, and then is that culture?
Yeah, that's
cool.
right.
Questions from the room. Does anybody have a question for any of these fabulous people? Megan.
This is a question for Christine. I've been involved in a working group for New South Wales whole of government return to work strategy, and one of the barriers that keeps coming up and discussing is around mobility across the public sector and how that can be addressed, because we see that if we tried to do that mobility ourselves as individual agencies, how are we going to do that successfully in terms of considering people's transferable skills, vocational options, etc., and then have a successful return to work outcome for that individual?
Yeah, so one of the avenues that's open to us in South Australia is that we have what we call a pre-publication notice of vacancies type. So, hello. So injured workers actually have access to that, and their case managers who are helping them find roles across the government. So they can put a role on hold, and there'll be a suitability assessment, and maybe a meet and greet, and if they meet, a few of the, requirements of the role, they actually get priority placement. So that's another thing that's kind of embedded in the public sector in South Australia.
I'm going to follow that up with another question for you. I think we're too close. I need to move away. So you have this list that comes out. People can look at it. They have somebody help them and they say, you may or may not be able to do this. Then they get put there and they have the meet and greet. How do you still... There's still going to be an inherent bias there about the fact that this person has been injured in a government department. There's still going to be something there about the fact that this is... whether they're a policy person, whether they're a paramedic, whether they're a teacher. So how do you overcome the bias, but also that from the interview, but also from that person in terms of their identity?
Yeah. So
easy question.
Yeah. Gee, it's a really tough one, isn't it? And I think I don't have all the answers, but again, I think it goes back to, even giving them the opportunity to showcase their skills and, go somewhere else for a trial. And there's an obligation now, an extra obligation for other agencies to take on injured workers. And there's things that you can potentially look at, like other parts of reporting, for how many injured workers actually go into other departments. You can count those and get reporting on that, I guess.
Beautiful.
But it's hard because a lot of those types of roles come with 7-day roster pay or shift work pay, and it's really hard to actually, even at a senior administrative type role, to meet those kinds of pay rates. So, I don't know, I don't have all the
So it's something
answers.
I'm guessing it comes down to a lot of support and a lot of individualisation and really making sure that you're listening and looking after those people and that they understand you're there to support them.
And the other thing in South Australia that I'm not sure that people are aware, but we have a cap scheme for workers' compensation, but in the government, in a lot of the EBs, they have what they call an additional compensation scheme. So gives workers, so the workers' compensation scheme is 2 years of income support plus 12 months of medicals. So the additional compensation scheme gives them, the support after, like what happens after workers' comp. But they do always have that priority placement, and again, it goes back to, how can we better support people to get those skills and, accept that maybe it's not a role for life. Yeah.
But it's something you can learn and something you can keep going with. And as Mary said, we're pretty excited you've started this. We're all going to be watching. Everyone's going to be watching you now. Any other questions for anyone? You've got actuaries, you've got insurers, you've got employers, we've got government sitting right there with Jason, and I'm just calling you government now, like TAC. Everything, you're just actuary, Ash, that's it. Not just, both of you are way more than that. Any other questions for this captive audience or for the fabulous Dr. Mary? Don't make me start to do table work with you all.
Yes, Rachel, I think table
Table work.
I think table work would be great. And what would be great is if people could share amongst themselves what they're seeing is working in whatever system they're in, but also what is not working. And maybe 10 minutes on that, and then sharing back for the group, because there's a lot of learnings in the audience that'd be great to tap into.
And if you're sitting by yourself or two people, how about we crowd around to a few tables? I reckon you two get to come down here. I think you two get to go back there. Come on. Don't upset Dr. Mary. No one upsets Dr. Mary. I'm looking at you, Mr. Donnelly. You can come over here. Do you want to jump over here too? Just start thinking as well about what you've been hearing up there and what you can take away from today, because that's the goal as well, for you to all be able to take something away and change something, make something better. Well, we've got 10 minutes left, so now we might actually just start to get all of the tables telling us some of the fabulous things they've been discussing, and then we'll be out of the way for the next lot who are starting to arrive a little bit early. So Tara, let's talk about what you're talking about. So Tara from DVA, let's talk about what you're doing with your employers.
Hello, so this is the first year that DVA has been at the conference. We've been having a great time. We're a representative from each of the states, so I'm over here from Western Australia. And I was just mentioning that in our new performance agreements this year as team...
Keep going.
As we have written into our performance agreement to... we have to demonstrate that we are conscious of and showing our social safety. So we have to meet frequently with our team members. We have to be reviewing phone calls,
Here you go.
supporting them in every way we can, so that they're learning to do their job the best that they can do, given the clients that we assist on a day-to-day basis and the impact that the sharing of the stories with those our employees have on their mental health.
Thank you. And as we were discussing it, that's a big one, you know. If you're the person who's looking after those claims and having those conversations constantly, it also affects you. So being able to look after your people is a huge thing, and having it built into the KPIs. I'm going to jump over to here briefly. Was there anything you were discussing that you would like to share about what you're doing differently, something you're trying, issues you're having? Here you go.
Hi, Karen Vanderhoeven from the Insurance Commission in Western Australia, looking after the public service over there. So was super interested to hear about what you're doing in South Australia at the Public Service Commission level with accountability and the other policy about being able to get workers across government, or it's one employer, because we have issues in that area, and I think we really were mainly talking about the issues that we were having, and getting that ownership and it drilling down. And everybody on the face level that's working with injured workers are working really hard and trying so many different things, and it's hard to get the traction that's necessary. So, yeah, it's hard, but it was interesting to hear the education department's costs going downwards when I think about ours in WA, and the differences maybe in how the school structures and things like that, and whether it's the buy-in at the site level, the line managers, middle management is really what we're talking about.
Let's just touch on that comment about education.
We're not going to talk about specific employers, but so they when we look at the when we look at the experience across different large government agencies, there's a capability difference across each of those agencies. And some of the good performance that we've seen, we can trace back to really good middle management in injury management, that local team level that knows how to do return to work planning and knows how to influence the local school principal, which probably extends to that other conversation we're having about what the boundaries are of the obligations of our schemes versus the employers, and how to land those accountabilities and land those obligations and not step into the breach when it's vacated.
That's really interesting, especially in government. Here you go.
Just a different perspective. I think all change comes from sociological change. I think we've got to make areas like football teams, everybody's got to be cheering at their area level or their agency level. If you can't compete between agencies and you compete against yourself year to year, but you've got to make it a competition, and the biggest change will come from sociological change, how that's managed, how we become a football team. So Western Australia versus Victoria on this table, start the competition now.
Interesting, and that does go back to that accountabilities of team to team, and we've heard people, Andrew McGarity, who is on holidays, I think at the moment, which is great for him, talks about the fact that he when he started to influence the teams, it was giving money back, and the first fire chief at one place managed to get enough money to get himself a fire engine, and all of a sudden everybody else wanted the fire engine, and it changed that culture. But going back to that as well, when you're embedded, government, a lot of the time you are embedded with your people, so where is that divide? It's a really interesting one. Over here, quickly.
Alison Hall from Cogent Thinking. I was actually asking the question, we work with some government agencies in early intervention, and I mean early intervention pre-claim. So we work with a lot of large employers that successfully run early intervention because they know that their people have a better recovery, which is good for them and good for their business economically. But we find various resistance when we're engaging in the public sector, and budget is often the reason why they can't fund effective early intervention, yet the ROI is clear when you look at it in the private sector. So we were talking about why and unpacking that a little.
I think we could do a whole nother session on that, which we won't touch on right now, but it's interesting, and that's why we're looking now at those levers and what can you do, you know? Is it going in at different levels or, you know, starting from the top down and putting things in letters to ministers saying that they're now accountable? Is it starting from that bottom up or that middle, or is it a combination of all of it? And how do you turn such a big ship around? We do have 5 more minutes. Are there any other tables that we'd like to share?
This is a little bit similar to Alison's perspective, but Sam Bruce, COO of ReadyMed, one of the observations that we were discussing was that in the private sector nowadays, medium and large employers, generally speaking, have treatment providers offering early intervention or other clinical treatment, treatment specifically, that develop relationships with those agencies or those businesses so that they deeply understand the work. And when you're talking about public sector and how it is very tied up with identity and very specific work, and public sector organisations, gross generalisation, generally steer away from treatment providers that they develop relationships with. And choice and control is obviously always important in private or public sector. However, deep knowledge of workplaces from medical specialists and allied health professionals deeply connects return to work outcomes, and it's just interesting that doesn't seem to happen in the public sector very much, and I was wondering if any of the panel had a perspective on that really.
I might just answer that if I could and then wrap up, because I think the next slide is coming in.
Yeah, they are.
So just one point on the public sector. So ACT Gov does this. They have that early intervention approach, so they'll refer pre-claim, physical and psych, and they're really pleased with it. But it's set up in their legislation, so it can happen, and they've got close relationships with all the referring, relevant departments. So there is a structure for it, but I think with most government departments that's missing. Yeah. So that's the big problem there. Thank you for those contributions, and sorry we didn't get to you in the tables over yonder for your contribution. So one of the themes of this conference is collaboration. And so just like to say thank you for everyone today for collaborating and continuing the theme of that. It's a shared problem, as David Fryer says, 80%, our shared challenges, we've got commonalities, and this is a really huge one. So thanks for sharing today, each of the panel members. Very grateful for your input time, all the prep time, as well as thinking time and their time today. Say big thank you to the panel. And thanks everyone for your involvement.
And well done to me too.
It just, no, it just was literally you'd be cutting out while you were talking, then you go back in.
Do you want me to hold it until you're ready? Yep. Yeah.
Hey there, guys. Are you on here next? Yes. Cool. Do you want to use handhelds?
For our panels?
Yep.
Yeah, actually, because I'm going to sit down too with them.
Yep. So you don't want to use that at all?
I'll use that to start with.
Start, yep.
And then once we all sit down for the discussion, we'll use handhelds.
Yep. Cool.
Is that okay?
Yeah, no worries. There's a clicker as well.
Awesome. Thank you.
Great, just go forward. First, go back. We've got, this one is yours, right?
Yep. So, thank you. So, that's what we'll start with looking at today. And then we'll have a look at you guys. Today we'll be hearing from panel members that and introduced and then
You didn't even notice. Yes, you float. You didn't know. One that wants his nose, food wants something else, Adam was saying interviews, and it all coordinated.
There's a lot of them. They must have got sick.
No, there was like 4 people changing slides, changing notes, bringing audio messages, mental.
I've usually found they normally go, yeah, no problem.
Nothing was too hard for them. Nothing at all was too hard for them. At one stage, I asked one little thing to be changed. know. He did make a real point about it when he did join me. Yeah, he's like, Alicia, it's a solace. I was like, it seems like a little kid. I was like a joke. It was funny. In front of Steve Jack. Yeah. He said to solace. And I said, Michael Miller. Yeah. 12 years I have known you, you still can't say my name. And he's, and Steve J was, I lost it laughing. So, I did apologise. Yeah, I was like, hey, Jeremy. Yes, yes. It's like, ooh. Martin was very good. Yeah, I know. Yeah, it was very good. Martin's very good. Yeah, I know. Yeah. Rach, do you want to go and like procure some crowds? I was just saying, we're going to everyone turn up like it's ready because everything's running late. Yeah, okay. So the sessions are all running a bit behind. Yeah, because I mean this would usually be so packed out.
That's my only Saturday break. Yeah, they're by 5. So well, I can use your. Well, this is even cozier, and this has got to be the best session of the last 2 days. Come in, everyone. They even need to speak when they might even need a microphone.
Come in, everybody. I promise I will not call out anyone or ask any questions of anyone.
All the questions will be easy.
Yeah. All right. I feel as though we probably don't even need, we may not even need microphones, maybe not. Right, of course. We're good to go? All right. Well, welcome everyone to day 2 of PIEF. For those of you who I don't know, which is a few of you, my name is Alicia Solis. I'm the Executive General Manager of Workers' Compensation for our GAO brand as part of the Suncorp Group, and I am delighted to be hosting this session. Thank you so much for joining us. a few things before we jump into introductions. I do want to start by saying that at Suncorp we do understand the profound impact of road trauma and what it does have, not just on individuals but also on families, but also on workplaces and communities. That's why we're proud to support the Australian Road Safety Foundation and its mission to make road safety a core part of workplace risk management. To open up today's session, I am delighted to introduce Russell White from the Australian Road Safety Foundation. Russell has been a passionate advocate for road safety for many years, and today he'll help us understand why this issue is not just a transport concern, but a critical workplace risk that affects us all. Before I do hand over to Russell, I'd also like to introduce some star people within my team. We've got Danelle Carty, who is our Executive Manager for the Eastern Region of Underwritten Workers' Compensation. Danelle has been with us for 17 years, so an experience in the personal injury insurance business. She brings deep expertise into underwriting, claims management and key account leadership. She is passionate about building strong teams and partnerships and delivering strong results through collaboration and thorough understanding of underwriting landscape. We've also got Michael Walsh, otherwise known as Walshy, who is from the Wild West over in Perth. He is our manager of risk management solutions for GIO workers' compensation, and with more than 2 decades of experience across industries including mining, education and healthcare. Michael is a leader in workplace risk strategy. His insights into WHS and compensation schemes are invaluable, and we explore how to better support our people and workplaces. So, I know it's a small crowd, but round of applause. I know there's many of you joining online as well. A little bit of context, I'm not sure if I mentioned this, Russell, we actually do have a live stream, and we've live streamed this across all of our Suncorp offices around Australia as well. So it's an absolute pleasure to have you here. Lots of people in Suncorp know who you are, Russell, so I'm going to hand the mic to you and let you do your thing. Thanks.
Thanks, Alicia. Thank you so much. And again, thank you, everybody, for being here and for those joining us virtually too. It's lovely to have... I think it's working. Just, there we go, we're back. This is a topic that's really passionate to me. It's been my career pretty much since 1990, and there was a number of reasons which I'll maybe talk about a little bit later as to why that is. But this whole area of work-related road safety is a complete other subgroup underneath the road safety platform. So I think we all sort of think about road safety, and there's probably a certain image that comes either mentally to our minds or to what most people think road safety is. And I just want to maybe just check for the audience here, like hands up if you drove to this event, caught an Uber, caught some other form of public transport, walked. Who's not sure how they got here? There's usually some person was on the hand going, I'm not sure how I got here. Transport is such a massive thing, and we drive or we use the roads for work all the time. Quite often when I talk about this space, a lot of people say, oh, but we've only got the big trucks. We do that. We do training for our big trucks. So we've got a certain approach for our big vehicles because the mentality is that that's when we talk about work-related road safety, that it's the big stuff. And then when you say to them, but what about all your light vehicle fleet? How many of those have you got? Oh, we've got 300 or 400. We've got 20. We've got 2,000. What do you do for that? Oh, nothing, they're just cars. So it comes to a point where we need to start to change the narrative as to why this is important. And I think if we're looking at the slide that's up here, if this doesn't sort of really put a rock in people's shoe, I'm not sure what will. But clearly the leading cause of work-related deaths and injuries are vehicle incidents. And if you just let that sink in for a minute, many organisations that I go to will look at road safety and go, well, yeah, we think it's the thing, but we're not really sure how to handle it. they'll have a whole stack of countermeasures around other things, which not to say those other issues aren't important, slips, trips, falls, those sorts of things. But there'll be virtually nothing on vehicle safety. And as a road safety professional and someone who's really passionate about trying to make a change, I think work-related road safety represents our single best opportunity to improve road safety outcomes across the board. And some of you may or may not know, but our road toll has gone up year on year for the last 4 years by significant numbers. And yet there's hardly a mention about that. So my concern is, how bad does the road toll have to get before we start really seeing change? Is that 2,000 people? Is it 3,000 people? Is it 5,000 people? Is it like it was back in the 1970s of nearly 4,000 people a year dying? So we are at a critical point, and in road safety generally, but I think road safety, work-related road safety, has a huge opportunity to change things. And it is in legislation. The vehicle is a workplace. Whether that's a private vehicle or whatever, if they're using a vehicle for work purposes, private or badged, it's part of the workplace. And so we need to have an intensified focus on this issue. And also too, I should say, it's not just fatalities. I mean, the whole thing of this event is about the injury and the recovery. And sometimes even a very minor crash can have a huge psychological or social change or social impact, which goes far beyond the social or the physical injury. So that's why I'm so passionate about it. That's why I'm so proud of this relationship that we have with the whole Suncorp group, and I guess looking at how do we improve this area, as I said, because I think it represents the best chance we've got completely to improve road safety generally.
Sorry, we're sharing microphones here. We might see if we can get another mic. You know, it's really interesting. I've known Russell for a long time now, and in previous roles I've looked after the CTP portfolio. And having worked across both CTP and workers' comp, I personally had not made that correlation in terms of how many incidents actually occur in workers' compensation claims off the back of motor and road incidents. So why do you think that generally in society there is not that correlation, and why do you think there's not the same level of urgency that is applied to road trauma and road incidents as what there is workplace incidents when we're talking about workers' compensation?
That's a massive question, Alicia. I wish I had the answer to it. I don't know. I think the road safety space, I think, is so often seen as happenstance, or it's almost inevitable. And one of the things, we've been doing round tables around the country looking at this particular issue, and I think one of the things that is intriguing to me is the level of disconnect that people seem to have around an incident that happened on a factory floor. We've had incidents at theme parks in Queensland where those businesses have still not fully recovered from those things. Yet worse may have happened on the road out front of those venues, and that doesn't rate a mention. There's a terminology called a scandal of tolerance that's often used, where we just tend to look at road trauma as collateral damage in many ways. And I think because it does fall through the cracks. Is it a police problem? Is it a work cover problem? Is it a employer problem? Is it a personal problem? Quite often, I think if there was an incident again, say at a work site, that place would close down. There'd be a full investigation. We have it happen on the road, and it's just how quickly can we clean it up and get the traffic moving again. And I think fundamentally that's one of the things that we've got to try and change. I'm not suggesting that's easy to do, but I think it's sort of a symptom of road safety generally. People think it's often someone else's problem, and even in a workplace sense. When I first started on this journey, you would go to knock on the door at the fleet manager, and they'd say, "Oh no, that's a OH&S problem. You've got to go and see OH&S." You go to OH&S, knock on their door. "Oh no, that's a fleet problem." So there's a disconnect between the management of the asset and the management of the people, and I think because so often it falls through those cracks. But That's probably a short answer to a very long question.
I think very, very valid points there, and I think, you know, that's why absolutely we want to leverage the work that you're doing as part of Australian Road Safety Foundation and think about how we, as one of the major insurers in Australia, can start thinking about how we advocate for change with our regulators, with government and so on. So thanks, Russell. Danelle, let's shift some gears. Let's throw over to you now. I mean, you see this day to day in terms of the interactions that you have, not only with our people on the ground, but also with our brokers and clients directly as well. Reflecting on the recent work-related roundtable, what key challenges did you observe from the insurer's perspective regarding employer accountability and management of work-related travel risks, especially in non-traditional transport settings? Do you have a...
Thank you, guys. Great to be here. Thank you all for joining us. As Alicia mentioned, I had the privilege of attending the most recent Road Safety Forum in Sydney. It was a roundtable with various employers. We had a superintendent attend, we had regulators attend, and government representation, and it was a really great discussion. And I suppose in reflection, coming from an underwriting perspective myself, really was keen to hear what are those key challenges that we're seeing across road safety, and I was really intrigued as to what the conversation brought about. There was 3 key themes that really resonated as key challenges, I suppose, made me reflect. The first of which was really that there was a lack of awareness of this being a real issue. Russell talked about some statistics that really hit home, and I suppose coming from a workers' compensation background, we often talk about slips, trips and falls within the workplace, manual handling injuries. We don't have a conversation about the number one biggest contributor to workplace injury and time off work, which is road safety. And for all those reasons that we talked about here and how we got there today, the risk is real. Second of all, Russell, you touched on it earlier, but it was around there's a real lack of understanding or accountability within a workplace as to whose responsibility it is. So it was very apparent that when it's not just a workers' comp issue and when it sits outside of that, when it goes outside of the workplace, there's a lot of ambiguity about where that responsibility sits. And then thirdly, I suppose we all kind of really reflected on the impact of an individual as risk-taking tolerance as just such a key component of preventative measures to keep our employees safe. And, you know, the real role of an employer perhaps to have more of those conversations, instilling it with their employees within the workplace around road safety and the risks that they're taking day in and day out.
Thanks, Danelle. Walshy, our data man, you're in this, you know, every single day looking at risks, you're looking at risk mitigation, you're looking at all the statistics, and you certainly bring to my attention very frequently the risks that we have, particularly around road incidents. So, while workplace road safety risks get a high focus in the traditional transport industry, from an insurer, what critical road-related workplace risks are you seeing outside of transport?
Yeah, it's a really good question. What we're seeing across the group in our own data and also schemes data as well, it's not necessarily someone that's employed in a role within transport as a driver that's their occupation to be on the road, but their occupation might be to attend sites or to attend other areas of employment as part of their role. So you're looking at those type of industries at the moment. We're seeing quite a lot in the healthcare and community care sector. We're seeing obviously a big increase of community care providers that are out there in the community, working in the community. So travelling to different sites on a regular basis, on a frequent basis. So they're having higher exposure levels. Construction, utilities, these are other industries. It's not just the transport industry. I know the transport industry over the last 40 years have done initiatives. They've got, chain of responsibility programs. They've got some pretty robust fatigue management guidelines. but I challenge of what other industries are doing in that space, because we are seeing those risks coming from different industries. And then you're looking at those systematic, risk controls as well. How high is it on the priority list for employers? Because it might not happen frequently, but when it does happen, we know can be quite serious. So it's looking at those system areas, our system processes within a company. Do they have that fit for purpose policy on road safety? Is there, as Danelle kind of called out, that accountability? We're seeing those as risks because we're not seeing those mapped in some of these organisations, and some of this data tells that. Especially when we go out after the event and review some of these customers, systems, they're not having some of these kind of areas being met. So how they're mapping these risks in their business, it's a big thing.
So a question without notice, I'm sorry, I always do this. What sort of response do you get from our clients when you're going out there and you're mapping some of these risks back to their workplace practices? Are you getting a favourable response? Are you getting an open response? Are you getting...
Absolutely. Yeah. I mean, like exactly what Russell said, this is the workplace for people. And driving is a workplace function. So it's, having the ability to map those particular risks out and what's that exposure level look like at an employer level. The employers, when they are doing these activities, it's great that they, it's an enlightening process because they sometimes don't realise how many activities involve, road transport exposures. Yeah. So having the ability just to map that out, I think is one step to then putting in the appropriate controls.
And knowing as well we're there to help protect them and
Absolutely.
mitigate their risk in their workplace and keep their people safe
Exactly.
on the roads. Awesome. Thank you. Russell, well, let's come back to you. Another big question for you. So we've touched on the challenge of recognising and prioritising road-related risks across different workplace settings. From your work with Australian Road Safety Foundation, what have you seen in terms of the wider societal and health system impacts when these risks aren't addressed? And how can that evidence help shift organisational and regulatory mindset?
It's again a great question. I think the things that the foundation does on a day-to-day basis is that we deal with people, individuals, families who have lost someone as a result of a vehicle incident. And that's just not in the workplace, but it's across the board. And I'm sure anybody in that same space would have the same view that the numbers we hear don't really reflect the human impact of what goes on. And when you deal with those people on a day-to-day basis, if you could turn back time and take that pain away from them, you would do it in a heartbeat. And so I think this space offers a number of challenges because of what we've spoken about already, the disconnect, the uncertainty of who's responsible, of the increase in the road toll itself. So even just operating your vehicles, you're inherently operating it now in a way more risky environment than you were 4 years ago. Why that is, we still don't quite know. Whatever happens after COVID, there's been bigger things that have occurred society-wise, and so that's changed that as well. But I think the challenge that we face is how do we get it more on the agenda to realise, because I've often said this in seminars, if we took vehicle incident out as the number one thing and replaced that with photocopier or some other coffee machine or whatever, change would happen really quickly. Somehow, because it's a vehicle thing, we're not really sure. And so I think that's one of the first things we've got to do. And that's one of the reasons these roundtables were so important, is we want to lobby federal government and also policy holders, policy advisors to raise this way more, because the human cost is immense. And one of the figures that I'd seen years and years ago, and this is again a 2002 figure, was that the actual cost to a business for a vehicle incident can be anything between 8 to 36 times the repair cost of the vehicle. And again, that's 2002 number, so I hate to think what it is now. Actually, I'd love to get some research as to what that current figure actually is. So the cost to the business is enormous, the cost to society is enormous, and yet we're sort of still not quite giving it, or we're not giving it the level of focus that it really needs. So the impacts are massive. And I should also say too, yes, we talk about the big crash, but again, I've equally seen people have musculoskeletal problems just because of no, believe it or not, there is ergonomics for driving a car. In the cab ride we had coming from the airport yesterday, saw some very unergonomic ways of driving. So the poor cab driver inadvertently got a driving lesson on his way to dropping me off to the hotel. But things, just repetitive strain injury from palming the steering wheel, having your posture up high. We wouldn't let someone sit at a workstation like that and type away on the keys of the computer, or we wouldn't make them do that. But we're actually doing that in a car, and their office is also doing this as well. It's not a static thing. So when we talk about the impact, yes, the fatality is the top line, major injuries underneath that, but then you've got a whole stack of other potential musculoskeletal issues that lie underneath that as well. Yeah, so it's complex.
Even you just saying, I didn't even make the correlation around posture ergonomics in the car, and looking after yourself in the car is just as important as doing it in the workplace.
Even more so, because again, the car's doing this. It's accelerating, braking, cornering, and the more your posture's moving, all that's creating not only postural sway, which leads to the ergonomic problems, but if you get into big strife, all of that postural movement actually makes an evasive manoeuvre, for example, much worse, much more difficult, because your whole body's involved in it. Because at 100 k's, the car can handle 3 very small movements of the wheel to go from around an object from a left lane, right lane to left lane. If you give it a big reef, you've set off a chain reaction you'll probably not recover from. And people don't. That's never generally plugged in.
Yeah, we absolutely need to shine the light on it. And your statistic, can't remember what you've just said specifically now, but the cost of road incidents in the workplace. So I was doing the quick correlation in terms of the data that we see around psych claims. We're all talking about psych claims, primary and secondary psych. We see in our data the cost of a psychiatric claim is usually 4 to 5 times the cost of a physical injury claim, but it feels like we almost need to wash the data over in terms of road incidents to see how that matches up. And are we, psych is very important. I feel like we've got the right strategies and awareness in the industry, but it doesn't feel like we've got the right strategies in place when it comes to road incidents. So would love to do that deep dive with you at some point, Russell.
100%.
Yeah. Now, Danelle, you assess risk every single day in your role within underwriting. So considering everything that you've heard today, considering everything that you've seen in terms of the risk and exposure from a workers' compensation perspective, I'm keen to get your thoughts on the emergence and importance of data and technology.
Thanks, Alicia. So from an underwriting background, obviously data and facts drive my decision making day in and day out. And looking at an employer and the specific risk and exposure of road safety, data is integral. I think you've probably already picked up from some of Russell's comments, through the date of some of that data reference points, is that there's a lot of gaps in terms of that data capture across the nation and across the world. We capture data, and when those incidents occur from an MVA perspective through CTP, obviously, and sometimes with workers' comp through journey claims in compensable scenarios. But what we don't capture is the real toll and cost on employees when they are crossing roads or they're inadvertently, indirectly exposed due to a motor vehicle. So that data is definitely in its infancy, I would say. I think you would agree, Russell. And I suppose this whole advocacy around the awareness piece with employers is that how do we look to solve for that? Technology is a really interesting one. We're obviously moving at rapid pace across all components of injury and wellness and the like, and AI is taking over as well, which is exciting to watch. But from an employer space, it plays a really pivotal role. We have seen a really fantastic, I suppose, emergence, particularly in industries like transport, through wearable technology with high manual handling, fatigue management through those transport and trucking industries, which has really progressed, and it's really reassuring to see. And we're reassured, I suppose, by the data and facts that will come out of that. I suppose sort of touching on a point that you made earlier around that grey fleet and some of the challenges that we see with people using their own vehicles now through NDIS. They're going from job to job. We've got a gig economy which is booming. That exposure becomes more broad, and the use of technology will play a pivotal role in how we sort of mitigate that exposure moving forward. I know us whilst I'm not in the consumer space, I know you may have seen the Amy app, a little plug there, but we are definitely taking that forward-thinking approach in terms of supporting the individuals, which is a point I made there earlier around those challenges, and informing them about their behaviours. So I think we'll see a continued emergence of that technology in that space, and that's obviously opt-in and optional, but really excited to see what kind of comes out of that space that can lead to that prevention and, I suppose, a more higher agenda around the importance of this conversation.
You think about it as well, my time in consumer and managing motor claims, you know, your key, is it telematics, is that what it's called? Your key gives you so much data, insights. It tells you how fast you were going on certain vehicles, how fast you were going, when you were braking, how you turned a corner. I mean, surely we could be using that sort of data in workers' comp to help us with risk mitigation, education programs. Again, a question without notice, but obviously an opportunity more broadly, I imagine.
Absolutely, and the telematics, if anyone that's used it, it actually has come quite a long way from when it was implemented many, many years ago, and we're seeing the use of other apps. Live 360 tracks your behaviours as well. It's a free app, but so absolutely, yeah.
Very good, thanks Janelle. Michael, what controls should businesses be focusing on to manage workplace road safety risk and injury management post-incidents?
Just probably strengthening exactly what Danelle was saying. Telematics is obviously it's going leaps and bounds, and we're getting some really good, robust data coming out from telematics now. So utilising that data in designing training programs for your own employees and workers, giving them their own insights or group insights to saying, well, this is how we're changing our behaviour or wanting to change our behaviour when it comes to road safety. I think that's probably a good area of opportunity, is utilising that telematics data, like you mentioned. But I also you could go back to what I was mentioning before around just that key accountability. What does that look like in an organisation? Does actually businesses mapped out, well, who has the responsibility when it comes to road safety, and how is that implemented within your own business operations? So going to looking at that from having a road safety process and policy in your business, but also how are your workforce, how are you making a due diligence process involved of them knowing those processes, having the right training, understanding those behaviours that they need to upstill by. So these are the type of things that we I very much encourage organisations to look at. There's probably other things as well when we're looking at fatigue management is probably a big area of focus, especially again in the transport sector. It's been at a high focus for many years, but how can we instill that into other industries and operations that that have those fatigue management risks? So there's another couple of key areas that I think need to be focused on, in relation to how we change behaviour change within our organisations. But it's that due diligence piece. When we're looking at WHS legislation, like we've said before, that's a big piece. It's saying that someone has a driver's licence. Well, that's great, that's good, but what, as an employer, are you taking the next steps to manage that person and understanding that, well, are they compliant? Do they know those processes? Are they aware of the types of risks in your organisation when it comes to road safety? So it's having that ability in that conversation and making sure that that's followed up and recorded appropriately.
Thank you. Team, I can't believe we're already at time. Before I wrap up and throw for final comments, I do want to throw to the audience. And my technology does not like me. Oh, we have 3 questions. Thank you, Dean. Okay, we have 3 questions. So, do you have any examples of employers who are implementing vehicle safety and prevention strategies well? And how is this reflected in your workers' compensation underwriting practices? I reckon that's probably a Walshy and Danelle. Walshy.
what I am seeing are really good things that a lot of organisations are starting to do is mapping those particular risk exposures. What do they actually look like for the types of occupational roles in their organisation? So we have seen some providers in the healthcare sector, as an example. We are starting to see a big shift towards that. And then from that, rolling out design-tailored programs when it comes to understanding their what their responsibilities are. So we are seeing a bit of a shift in these couple of organisations, but it does come right from the top with that management commitment.
Thank you. Russell, 2 for you, if I may. We always see information about cars becoming safer, but injuries and deaths are increasing. What do you think is contributing to this?
Again, how long have we got? Alyssa, you're right. I mean, our fleet now is by far nationally is at its safest that we've ever seen it, and I think that's what's concerning about these road toll increases is why if the roads, yes, the roads always need to be better. I'm not denying that, but they haven't all crumbled into nothing where they're undrivable. The cars and the fleet is as safe as we've ever had it. There's more safety features coming. So the only thing that's left is the human factor. And one of the things I've often said, even federally, when we look at any road safety strategy, it's always led by infrastructure, police, car manufacturing, it goes down the line. And then on the last page, there might be a cursory mention of, and the people, we need to make them safer too. And I think we have to flip that and not saying don't do what we're currently doing, but we need to reverse it to make the people part first, and then everything else falls from there. I think we were talking about this even before we came on stage. I think there is a bit of complacency that, the car will fix it. The car does all that, doesn't it? And, I think we tend to sort of treat those safety features as, if they deploy all the time, well, that's no problem. But that's like launching your lifeboats, on a cruise ship every 45 minutes. It wouldn't be acceptable there. And I think we've got to try and change that narrative around and again, that's why this is important. It's changing the narrative around, it is something we do all the day, every day. We all do it. But because we do it every day, we tend to think because nothing bad happened yesterday or the day before, we get really complacent with habits. There has been some social change towards risk. And sadly, I think we're also dealing in a road safety space with issues that quite frankly probably start at school. The social things, it ends up in our patch. Youth crime ends up in our patch. Social views around authority and how we respect police or teachers, all that ends up in our space. Because and then what happens is we can go through all this education time, then suddenly when they get a licence, you go, now you've really got to stick to the rules and you can't do anything. And so that's, again, part of that disconnect. So I think there's a broader social thing there. Again, not easy. I'm not suggesting it's easy to change at all, but we've got some work to do.
Absolutely, some very interesting points. And final question, what's the biggest trend that you've seen over the last few years regarding the attitude to road safety? It's probably a little bit of what you just said then.
Yeah, I think there's a real apathy. How often have you spoken to someone and they'll say, I was okay, I was only driving? You're actually doing the most dangerous thing you're going to do on a day-to-day basis. And I'm kind of an interesting example in the road safety space. I love driving. I love cars. I always have. Love it. For me, being on the road isn't a great feeling. It's something I love. It's why I love teaching. It's why I love doing what I do. And so for me, it's just part of my life. I always want to get better. I always want to... And I think this goes back to what we were saying before about the app. A lot of times people don't know what good looks like. If you said to the average person, you a good driver? Oh, yeah. It's all those other people there, they're the problems. But the great thing about having something like the app is you suddenly have now some parameters about what good looks like. And like in Formula One, the engineers know exactly what the driver is doing and you can make adjustments to improve on that. And it's the same thing, I think, with things like the tech. We can start to look at attitude and how we can improve not only our own personal performance. I think that's the thing. They're 1%ers. They're not big things. But like a football team, cricket teams, whatever, it's the 1%ers that make the difference. So we've got some work to do. But again, I think for me, that's why I think this workplace-related it gives us our single best chance to make a massive change very quickly.
Yep, absolutely. I think I'm going to send you my almost 13-year-old son to teach him how to drive because
take him.
he gives me anxiety, just the conversations we have in the car and the sheer volume of music that he plays while we're driving Russell, which I say is very distracting. So I'm going to ship him over to Queensland in a couple of years' time.
I'll look after him.
Thank you, appreciate it. All right, team, we are at time. Thank you so much for shining the light on work-related road safety incidents and education. I hope, audience, you have taken something from that. Thank you so much for joining us today, and thank you for everyone online. A big round of applause for our panellists. Thanks so much.
Thank you. Thanks, everyone. Thank you.
Yeah, he was too. He was doing